Welcome everybody to the Evidence-Based Guidelines Subcommittee meeting on February 6th, 2025. We're happy everybody is here today, and I think we've got some steps to call ourselves to order, and I believe we need to go through roll call for those who are members. So is it Jessica who will do that, or is it Liz?
I believe I will be doing roll call.
Okay,
All right. Linnea Lindsay,
here.
Mimi McDonald,
Here.
Mark Buckles,
Here.
Deb Espicente,
Here.
Devin Consagara.
But he'll be missing.
Okay. Abigail Khan.
Here.
Larry Lyon. Not present. Kat Livingston.
So not present.
Judy Richardson.
Present.
And Leslie Sutton. Okay, that is roll call.
Thank you. And we should give a chance for members to declare any conflicts of interest with regard to any of the services discussed today. All right, with that, we'll start with our orientation presentation. As Linnea said, welcome to the Evidence-Based Guidelines Subcommittee. We are here as a very small part of a very large effort to eliminate health inequities by 2030 with our colleagues at OHA. Our purpose specifically here today is to develop reports to guide coverage for the Oregon Health Plan and other plans. And today we'll also be taking on some more unusual agenda items for this group, which is some topics related to the Benefit Update Project, which will more directly influence coverage for the Oregon Health Plan beginning in 2027. More on that later. Either way, these decisions will affect over 1 million OHP members, as well as their family, caregivers, and providers. As a reminder, we will not make any decisions today about individual care. This is a policy level body. EVGS's normal work is to develop these coverage guidances like the one we'll see today on surgeries for sleep apnea, as well as multi-sector interventions reports to guide coverage of health services by health plans. Reports are not final until approved by HERC, and they will be implemented at later dates. Often the considerations include what outcomes are important to patients, the assessment of the harms and benefits, the benefits and harms, the balance of those, patient values and preferences, stewardship of public resources, and the nature of our healthcare delivery system. For logistics members, I see you all on camera. That's great. If you need to step away, Daphne's not able to make it today. Had some urgent work to do, but message Jessica Malmstrom if you're stepping away, just to help us keep track of quorum for when we do the minutes. And you can also message Jessica with logistical issues. Sorry.
Go ahead. I'm sorry. Go ahead, Jason. I'm sorry.
Okay. One correction, it says that members can vote in the chat or verbally. We've had new training recently, and we need to do roll call for all votes. So Jessica will be walking us through that. Just adds a little more time, but it's a little more transparent to see everybody's vote. For those, we don't have anybody offering verbal testimony, but if you are observing the meeting today, and if you're having technical difficulties or have a question, you can use that Q&A feature, and one of us will respond if we are able. That's a best effort process. We want to focus mostly on the discussion in the meeting, but if we're able to answer it, we will. Otherwise, we will do our best to follow up. Chat and Q&A become part of the public record and may be released in a public records request. This meeting is recorded. Looks like we are recording and will be posted online probably next week. If you have questions that aren't answered during today's meeting, please email us at that address. herc.info@oha.oregon.gov. With that, we can go on. I do have one staff update, if I could do that before we review the minutes. Linnea, would that be all right? Just to make fewer transitions.
Certainly.
A couple of years ago, we completed a coverage guidance on pandas and pans. And that was later referenced in OHP coverage policy, as well as in a bill that passed the legislature and became a mandatory coverage for commercial insurance regulated by the state of Oregon. Recently, the American Academy of Pediatrics released a preprint document sort of along the same lines as our recommendation that came out of this group, but with a few more restrictions, specifically that certain settings needed that any infusions of intravenous immunoglobulins needed to happen in certain settings where safety could be assured, and that certain consultations needed to be had before a patient could receive that, just to make sure that they were getting the best therapy and the full range of possibilities had been considered. The preprint also does recognize pandas and pans as, or specifically PANS, I believe, as a real condition. I know some people had doubted that. It's kind of an emerging field of science over the past number of years, but it did recognize the condition as one that affects children. So that was discussed at our HERC meeting last month, and we had some discussion. There were some varied opinions. Leadership decided not to place any revisiting that on the agenda, and we did have some testimony about that, but I wanted to report that to you all as well, just since many of you worked on that project with us. The other thing that's going on is the legislature is in town in Salem. There are several bills related to our HERC work that I just want to mention. One is related to the Benefit Update Project, which we'll talk about in a bit. There are also some coverage mandates. Oh, and I guess Larry Lyon is here. Maybe, has he been promoted, Jessica? If you could promote him if he's not been. Sorry, there are a couple of bills that affect our HERC work, and one of them is on continuous glucose monitors, would require broader coverage. Another one is on biomarker tests, which is something we haven't worked on in this group, but we did with the Value-Based Benefits Subcommittee. There are a couple others. Liz, can you help me? Weight loss medications.
And besides that, also coverage for blood pressure cuffs,
Right.
clinically validated, and coronary artery calcium screenings.
And that last topic was addressed by VBVS fairly recently. There was a coverage guidance a number of years ago on that, and it would require coverage of that, pretty broad coverage. So we're watching those bills, and we'll keep you up to date. You never know what will happen in the legislature. There's also a bill requiring HERC to do a report on genital treatment, in line with some of the public testimony that's been heard in recent meetings at the HERC. If that bill were to go anywhere, that might come to the subcommittee. Again, with any of these bills, we don't know whether they will move forward, but they are on the horizon. So I thought you all might want to be aware. Those are my staff updates.
Thanks so much, Jason, for that. I do think now we need to move to approval of minutes from our last meeting, which was held in September, I believe, and September 19th, 2024. Hopefully there's somebody who will move to approve those. Any takers on that?
Make a motion to move to approve the minutes. This is Mimi McDonald.
Thank you, Mimi. Do I hear a second?
I second, Mark.
Thanks, Mark. And a second from Dr. Buchholz. So we have first and a second, and ready to take a vote. And I believe we have to take that vote. Is it auditory or in the chat? Which way, Jason?
It needs to be out loud.
Okay.
So
So I
Jessica
will,
will call the roll just like we did at the beginning. And if you're in favor, just say yes. If you're opposed, say no. And if you abstain, you can say abstain.
There we go.
all right. Linnea Lindsay,
Approve.
Mimi McDonald,
Approve.
Mark Buckles,
Approve.
Deb Espacente,
Approve.
and then skipping Devin, Abigail Khan,
Approve.
Larry Lyon,
Yep, I've approved them. I've read them, reviewed them. I approve.
and then Judy Richardson.
Abstain.
Stay. Okay. Motion passes.
Thank you. Thank you all for moving through that. So I think we move on to coverage guidance or to the staff report. Or did we flip those and now we're on to
Flip
coverage
those, sorry.
guidance?
Sorry, Linnea.
That's okay.
Okay.
Okay, I can take it away,
I think
if that's all right with you. That's good
Please
then?
go ahead.
Okay.
who's ever taking on coverage guidance.
That's me. That's me.
Yes, thank you.
So yeah, of course. So my name is Marcus Bachhuber, and I'm with the Center for Evidence-Based Policy. I've met many of you, but for those of you I haven't met in person, that's me, and I'm presenting this on behalf of our research team, comprised of Courtney Cooper, Jen Ryan, Shauna Durbin, and Firoze Darabi, and of course, Dr. Val King. So as far as disclosures, we have no conflicts of interest to disclose, and the slide set is designed for live presentation, and there's indication of the page numbers on relevant slides. And the full draft of the coverage guidance can be found in your meeting materials for today. Next slide, please. So just a little bit about the Center for Evidence-Based Policy. So we're contracted by OHA to carry out systematic evidence reviews according to what you all decide, what the HERC decides. We perform reviews using widely accepted and rigorous methods, and our staff have previously worked with governmental organizations that synthesize evidence and with other state Medicaid programs. We carry out the evidence review according to the scope assigned by HERC, and if we have questions or clarifications, we worked with HERC staff. And we provide the evidence review only, and we don't play any role in recommending coverage decisions or, of course, making those decisions, which is the job of you all. Next slide, please. Very grateful to our two appointed experts for this topic who agreed to stay on for part 2 of sleep apnea, Dr. Derek Lamb, who's a professor of otolaryngology, and Dr. Louis Libby, who's a sleep medicine specialist. And thank you both again. Next slide, please. So this topic may be familiar to most of you because it's the second part of a 2-part series on interventions for sleep apnea. The first was on hypoglossal nerve stimulation, and that was discussed at the last evidence-based guidelines subcommittee in September. And the decision at that time was to table the draft coverage and revisit in 1 year, just to remind everyone. Next slide, please. Okay, we'll jump in with the background. So these are some common abbreviations which you'll hear me define at first use, and this is mostly for reference for people looking at the presentation after the fact. Next slide, please. So we'll start off with some general background information, which may be familiar to many of you, especially from the last meeting, but I thought it was important to reiterate to make sure that we're all on the same page. So we'll start with the basics. So what is obstructive sleep apnea? It's a disorder where breathing is interrupted during sleep, resulting in disrupted sleep, low oxygen level of the blood, or both. It affects approximately 9 to 38% of the population. You can see a diagram here on the bottom. The left is a normal airway, so air is flowing freely from the nose and mouth into the airway and into the lungs. The second is a narrowed airway where the soft tissue of the throat and tongue are narrowing the airway, kind of narrowing the flow of oxygen. And the third is a closed airway. So the soft tissue of the throat has completely collapsed the airway, and there's no airflow into the lungs during sleep. And that's what we talk about when we talk about obstruction. Next slide. So OSA causes lack of restful sleep, daytime sleepiness, and headaches, among other symptoms, and it's associated with a reduced quality of life, poor work performance, increased motor vehicle collisions, and cardiovascular illnesses, including the ones that you see there. Next slide. OSA is diagnosed through testing in a sleep lab or at home to identify obstructive respiratory events. So we have two types of respiratory events. One is apnea, which is complete cessation of airflow, and the other is hypopnea, which is a reduction in airflow of 30% or more for 10 seconds or longer, with a reduction in oxygen saturation by 4% or more. There's multiple definitions of hypopnea, and this is the one that OHP uses and many other payers, including Medicare. The total count of these events, the apneas and hypopneas, is called the apnea-hypopnea index and expressed as the number of events per hour. And it allows you to classify OSA as mild, moderate, or severe. There's also another measure called the oxygen desaturation index, called the ODI, and that's just the count of desaturations. So that you'll also see that used. Next slide. When we're talking about patient-reported outcomes, there's several validated questionnaires for OSA, including the Epworth Sleepiness Scale, which measures daytime sleepiness, the Functional Outcomes of Sleep Questionnaire, or FOSQ, which measures sleep-related quality of life impairments. Then there's some general quality of life scales, which are sometimes used in research settings. You'll see me refer to. That can include the SF-36 and the EQ-5D. Those are general quality of life scales. Next slide, please. So CPAP is really the first line treatment for OSA. You can see there in the diagram, there's a mask over the nose, and the external device creates a constant flow of air to support the tissue of the upper airway to remain open. And that works for many people. If you could go to the next slide, please. Surgery is a second line treatment for OSA for people in whom the CPAP is not effective or inadequate or intolerable. So if you take a look at the cross-section of the tissue of the head and neck there, there's multiple places that can lead to the obstruction that can be addressed through surgery. There's the hard palate, which is one of the bones of the upper jaw, soft palate, which is the tissue, the tongue, and the palatine tonsils. Those are the main structures that surgery can address. It aims to mitigate or correct any abnormalities leading to obstruction. Surgical techniques are also constantly evolving, and that's something that we saw in the literature as well. Next slide, please. So OSA can originate from several different anatomical structures, as I just told you. And so one way to take a look at what structure is resulting in obstruction is called drug-induced sleep endoscopy, or DISE. That's a diagnostic test where a camera is inserted with a light dose of sedation to mimic sleep, because the patient's anatomy when they're sleeping can be different than when they're awake. And it's important for the surgeon to identify what structures are leading to the OSA. So surgeons can use DISE to guide their approach. They don't always, but they can use to guide their approach. Next slide, please. So recommendations for surgery and the specific procedure are really case by case. They're based on the patient's anatomy and the surgeon's clinical judgment. So surgeons can really select their patients, and patients can select their surgeons. And in this field, more than, as much as others, more than others potentially, a one-size-fits-all approach is not really clinically appropriate. There's patient variation in anatomy and surgeon variation in preferred procedures. So that complicates research and the application of research results to clinical care. Next slide, please. Taking a step back, there's some broader issues with surgical research I wanted to take a moment to talk about. Generally, surgical research includes fewer randomized controlled trials than other fields. And even in surgical RCTs, there are challenges using methods like blinding. So because surgery is a physical intervention on the body and not a pill, it's difficult to mask who's getting what an intervention, who's getting a placebo, if there even is one. Many of these methodological challenges are really inherent in the research. And so identification of them isn't a critique of the researchers themselves, because in many cases, they didn't really have an alternative. But at the same time, these limitations can really impair our ability to determine cause and effect. And so we need to highlight them or examine them when we find them. So in this review, we'll present study findings and note relevant methodological limitations, but I just wanted to let you all know some of these issues with the full body of surgical research out there. Next slide, please. So we'll start with the scope method, or the scope and methods, which will probably look familiar from last time. So we included adults with moderate to severe OSA and excluded children, mild OSA, and central sleep apnea, which is a different condition. Next slide. We looked at surgical airway interventions, including interventions of the upper pharyngeal area, the upper throat, the lower pharyngeal and laryngeal area, and then of the jaw. We excluded prescription drugs because those are managed by pharmacy and therapeutics outside of HERC. Hypoglossal nerve stimulation devices, which, as I mentioned, were covered in the last coverage guidance. Nasal surgeries alone, any airway surgeries that are no longer used in contemporary practice, and we got guidance on that from our experts. And tracheotomy or tracheostomy, so that's typically an intervention of last resort, except for very specific circumstances. For comparators, we included non-surgical OSA interventions like PAP or oral appliances. So those are mouth guards, basically, that can advance the mandible into a position to help open the airway. Waitlist or no treatment. And for our main key questions, we excluded head-to-head studies, but we'll look at head-to-head studies in our contextual questions a little bit later. For outcomes, HERC selected 2 critical outcomes, quality of life and procedure-related serious adverse events, and 3 important outcomes, that's change in OSA severity, daytime sleepiness, and major adverse cardiac events, or MACE. Next slide, please. For effectiveness, we included randomized controlled trials of any size with a duration of 12 weeks or greater, and comparative prospective cohort studies of more than 100 participants in a duration of 6 months or greater. For harms, we included the studies I just mentioned, as well as systematic reviews, single-arm prospective non-randomized studies of more than 100 participants, and registry studies with the definition you see there. Next slide, please. So you may wonder, why are there different designs that we included for different questions? So for effectiveness, the best design really gets at cause and effect, and we want to reduce or remove key biases like selection bias. So the main example here is, of course, the classic randomized double-blind placebo-controlled trial. And we really want to limit or exclude study designs that cannot help us determine cause and effect due to their biases. Now, flipping that on its head a little bit, when we look at harms, we know that randomized trials are often inadequate to determine safety because they're too small. And better designs have a large and representative sample with a long follow-up period, because those studies will help us identify rare events and late onset events. So some examples here are national registry studies and large cohort studies. And we really want to include all available data, no matter what it looks like. So flipping that on its head from effectiveness a bit. Next slide, please. And digging into that just a little bit more, when we talk about a comparison group, it's important to recognize that a comparison group is really crucial to help us get at cause and effect, especially in non-randomized studies. So you can see this graph here where we have OSA severity on the vertical axis, which higher level is more severe, so worse. And on the horizontal axis is 2 time points, a baseline and a follow-up. We have a hypothetical intervention, the blue arrow. And if you look at where the blue arrow is in the baseline and its decrease in the follow-up, you may conclude that the intervention had a really substantial effect. But if you then include a comparison or a control group, that orange arrow, then you can see that the difference between them in OSA severity was a lot smaller. And it may be significant, it may be clinically meaningful and important, but it's really crucial to gauge the intervention versus the control group to get the specific contribution of the intervention over and above what could have happened otherwise. Next slide, please. Taking a second to look at harms, we know that the rarer the adverse event, the larger the sample size needed to detect it. So we're really looking for all available data. And this graph is more statistically oriented, but on the vertical axis, you have a measure of statistical power. And on the horizontal axis is the sample size and observation time. So basically the amount of data. For statistical power, a general threshold for adequate power is 0.8 or 80% chance of detecting a difference if there actually is one. And each of the lines represents an adverse event in terms of rarity. So the gray line is an uncommon adverse event. And you can see it passes that threshold of adequate power at around 500, the sample size around 500. The red pink line is a more rare adverse event, and it crosses that threshold around 1,500. And the green line, which is a very rare adverse event, crosses that threshold even past where this graph is showing maybe 7,000, 8,000. So you can see that we really need a large amount of data to understand and identify rare events and late onset events. Just to note that this graph is for illustration purposes. It's not based on real data. It's a hypothetical to illustrate this point here. Next slide, please. So for our key questions, the first is, what is the effectiveness of surgery versus non-surgical treatments for OSA in adults? What are the harms of surgery for OSA? And how does effectiveness and harms of these interventions vary by intervention and patient characteristics? For our contextual questions, we have, what is the evidence for effectiveness of surgery for OSA on other outcomes from systematic reviews that include observational and non-randomized studies? So we'll get into a little bit more of what that means when we dig into that question. And then what is the comparative effectiveness of surgery for OSA from RCTs? So these are the head-to-head RCTs. And what is cost effectiveness of surgery for OSA? Next slide, please. So for search and study selection, we worked with an information specialist to develop a comprehensive search strategy. We looked at multiple clinical evidence databases. For policy items, we conducted targeted searches on Medline and websites you see there. We did expedited dual review of search results and risk of bias, and all methodological quality assessments were by dual independent review. Next slide, please. We summarize or synthesize the evidence using the GRADE method. So in this method, the confidence is expressed from very low to high. Very low being the true effect is likely to be substantially different from the estimate of the effect, and high is that we're very confident that the true effect lies close to that of the estimate of effect. And for all of these confidence ratings, I will tell you exactly why we rated it, why we did, so you have full transparency into that rating. For outcomes with no evidence, you'll see represented there by the 4 gray circles. Next slide, please. As I mentioned, and I will probably keep mentioning, we're extremely grateful. I was extremely grateful to be able to continue working with our local experts who really helped improve the quality and relevance of this evidence review. That's Drs. Lamb and Libby, who are on the call today. We met with them on several time points. They participated in scoping. They helped us review the list of included studies and clinical guidelines in October, and reviewed our findings and evidence synthesis about a month ago. In these meetings, we presented our findings and offered an open discussion of really any items, questions, comments, concerns, and we're of course invited to participate in the public meetings, and I'm glad they're here with us today. So thank you both again. So now we'll go on to the evidence review. Here's the flow diagram of our search. So we started with 2,390 unique publications. And through the rounds of screening, we ended up with 24 publications. So that's 13 studies in 13 studies in 16 publications, and 8 evidence-based recommendations. Next slide, please. When looking at the studies that met inclusion, we identified 3 surgeries. So the first and most common surgery identified was called uvulopalatal pharyngoplasty, or UPPP. I've also seen it abbreviated UP3 or just UPPP, and I'm told that any one of those is all right, so feel free to pick one that you like the best. This surgery, the purpose of it is to remove or reposition excess tissue from the throat and widen the airway. So you can see on the left, you have that excess tissue and the tonsils, and on the right after surgery, that excess tissue is removed or repositioned and the tonsils are removed. So UPPP typically includes tonsillectomy. Now, UPPP has evolved over the years, and it's not generally considered one specific procedure, but more of a family of different procedures that do the same thing. Barbed repositioning pharyngoplasty, which is the second surgery there, is one of those. It's kind of in the UPPP family, as we might refer to it. This procedure uses special sutures to reposition the pharyngeal palate muscle to widen the airway. It also typically has a tonsillectomy as part of it. The third surgery is jaw surgery, maxillomandibular advancement, or MMA. And this is very different in that it involves insertion of spacers into the upper and lower jaw bones to advance the jaw, move it forward, and widen the airway at multiple points. Next slide, please. So in total, through our searches, we identified studies looking at UPPP with tonsillectomy for a total of 13,125 participants. For MMA, a total of 631 participants. For barbed repositioning pharyngoplasty and tonsillectomy, it was 1,581 participants. There was one cohort study that met our inclusion criteria that looked at multi-level and multi-stage surgery. That first stage, they all received UPPP with or without tonsillectomy, depending. So we included this study when we looked at data around UPPP. Next slide, please. So we'll start off with our outcomes. So for quality of life, we found studies totaling 339 participants. We downgraded for risk of bias by 2 levels. The first level is that there was a lack of blinding, and quality of life is a patient-reported outcome. So that predisposes to biased outcome reporting. The second level was due to limited methods reporting in many of the studies and lack of funding information. And just as an additional limitation here, there's generally a short follow-up period relative to the intended length of the intervention. That's pretty consistent throughout these outcomes. Next slide, please. So overall, we assessed the level of evidence as, or the confidence rating as low confidence of a benefit. Again, a total of 339 participants. We can divide them up into 2 groups, surgery versus waitlist or no treatment. That was 1 RCT. And in that RCT, there was improvement in FOSQ, as well as the SF-36, both mental and physical health component. The second subcategory is surgery versus PAP or medical management, and that was 268 participants. And in that study, there was an improvement in the FOSQ, but not the EQ-5D. Statistically significant improvement in the FOSQ, but not the EQ-5D. And in the cohort study of multi-level, multi-stage surgery, there was no significant difference in the GBI, which is the Glasgow Benefit Inventory, which is a quality of life measure around the impact of surgery. Next slide, please. So to summarize, for FOSQ, 2 of the 2 studies met the minimal clinically important difference of 1 point. For the SF-36, 1 met the MCID for the mental health, but not the physical health component. For EQ-5D and GBI, they did not meet statistical significance. Next slide, please. Now we'll look at procedure-related serious adverse events. We use the definition found in Title 21 of the Code of Federal Regulations, which includes those adverse events you can see listed there. Study investigators, if they called an adverse event serious, we also counted it as serious. Sometimes they had a listing of an adverse event, such as hospitalization or repeat surgery, which they didn't necessarily call serious. They didn't use the word serious, but we cross-listed it with this listing here, and so we would label that as serious. So it was a combination of how the study investigators identified the adverse events and then using this definition by the FDA. Next slide, please. So in total, we found studies of around 15,503 participants, and we downgraded the studies for indirectness by 1 level. And indirectness is kind of whether the studies reflect the real world or to the degree to which the studies reflect the real world. So for some of the studies, we were unable to determine the level of serious. So if the study reported infections, we couldn't tell which were serious and which were not serious. They classified and categorized things differently, and we couldn't always tell which adverse events occurred for people with moderate to severe OSA versus milder OSA or who received the surgery for slightly different but related indications. Next slide, please. So for this outcome, we found moderate confidence of the harms. And so this is a little bit different. So the harms that are reported are actually harms that happened. We're just assessing it that we have moderate confidence that we understand the full scope and magnitude of the harms of these interventions. So we divided this by procedure. So for UPPP with tonsillectomy, the studies looked at together 13,291 participants. Total SAEs were 0 to 7.1%, repeat surgery 2.6%, death in 0 to 0.2%. And death here is just within 30 days of surgery and could not necessarily be attributed directly to the procedure. For some outcomes, like I mentioned, we couldn't determine seriousness, so postoperative bleeding, velopharyngeal insufficiency, which is a weakness in the structures separating the nose and the mouth that can lead to swallowing and speech difficulties, can be transient, can persist in some cases. we found that in 0.3 to 9.1%, and then infection. Next slide, please. For barbed repositioning pharyngoplasty, we found studies of 1,581 participants. Total SAEs were reported in 0%, and specific types of SAEs were not reported. Then for MMA, we found studies totaling 631 participants. Total SAEs were reported in 0 to 18%, with repeat surgery in 1.7%. But the listing of the specific types of SAEs weren't reported, so that 18% is a little bit of a black box, and that's all we got for that one, unfortunately. Next slide, please. Now moving on to OSA severity, we found 5 RCTs with a total of 315 participants. We downgraded this the confidence here for risk of bias by 1 level and indirectness by 1 level. So for risk of bias, we had some methodological limitations and author conflict of interest. And indirectness, some studies use a different definition of AHI than OHP does, which may overestimate the effect of surgery or allow for inclusion of people with more mild OSA. So it's slightly different population study than the population that it would apply to an OHP. So that's the downgrade for indirectness. Next slide, please. For findings here, looking at, again, surgery versus waitlist, that was a total of 163 participants. There were 3 studies that looked at surgery versus waitlist, and all of them found improvements in, the first study found improvements in AHI, ODI, and RDI. The second one found improvement in AHI, but not RDI. And the third one on barbed repositioning pharyngoplasty found improvements in AHI and ODI. Overall, we rated this outcome as low confidence of the benefit because of the downgrades I mentioned earlier. Next slide, please. Then for surgery versus PAP or medical management, there were 2 RCTs totaling 152 participants. The first found improvements in all indices of OSA severity that they looked at, and the second for MMA found no significant difference in AHI. Next slide, please. Just to summarize overall, for AHI, 4 out of 5 studies met the minimal clinically important difference. 3 out of 3 studies met it for ODI, and 1 out of 2 met it for RDI. And interestingly, the authors of this RCT proposed what they called a sufficiently important difference of 20 events per hour. So that's higher than the 5 events per hour that we found. And that 20 is supposed to account for the risks of surgery or to justify the risks of surgery. So looking at that sufficiently important difference of 20 events per hour, the 2 out of 5 studies that we looked at met that. Next slide, please. Now moving on to daytime sleepiness, we found studies totaling 481 participants. We downgraded the confidence for risk of bias by 2 levels. This is similar to quality of life. There was lack of blinding in a patient-reported outcome, so that predisposes to some biased reporting. And there's lack of some methodological information as well as author conflict of interest. Next slide, please. For this one, we rated overall low confidence of a benefit. For surgery versus waitlist, there were reductions in daytime sleepiness for all 3 studies. Then for surgery versus PAP or medical management, there was only reduction in daytime sleepiness for the 1 study of modified UPPP and tongue reduction, but not for the other studies of multi-level, multi-stage surgery and MMA. Next slide, please. As another overall summary, 4 of 6 met the minimally clinically important difference of greater than or equal to 2 points, and 4 of 6 met the sufficiently important difference proposed by those authors of greater than or equal to 3 points. Next slide, please. Rounding out our outcomes, we have major adverse cardiac events, and we couldn't find any eligible studies that reported this outcome, so we have it listed there as no data. Moving on to our contextual questions, the first is looking at key endpoints from systematic reviews. So the purpose of this contextual question is to broaden our search. And we couldn't, a systematic search of individual studies isn't feasible, but what we could do is a search of systematic reviews that included all different types of studies, even if they were less reliable, just to get a sense of what's out there as far as other outcomes that the commission may feel is important. So we identified 3 systematic reviews, including studies examining mortality, stroke or transient ischemic attack, and cardiac arrhythmia. For mortality, there were inconsistent results, with the most recent study in 2004 finding UPPP compared with CPAP to be associated with lower mortality. There's about 5 observational studies. For stroke or transient ischemic attack, UPPP versus no intervention was associated with a lower risk of stroke. And cardiac arrhythmia, there was no significant difference with UPPP, and that was 1 observational study. Next slide, please. For the second contextual question, this is head-to-head RCTs. We found 5 studies of clinically, of different surgeries still in clinical practice. Most of these were variations of UPPP compared to a classic or a modified UPPP. But I just want to draw your attention to the last line, which is the Sunman trial from 2002. That looked at tonsillectomy alone versus a modified UPPP in select patients. They found that the outcomes were fairly similar in those select patients with a mild advantage of tonsillectomy alone on AHI, but the results were quite similar. So that one we'll talk about when we get to the discussion. Next slide, please. For cost effectiveness, we prepared this in anticipation of implementation of the Senate bill. And so we didn't consider any information related to or derived from QALYs. And at the time of our search, we didn't find any US-based cost effectiveness studies that included measures of cost effectiveness other than QALY or QALY-derived measures. Next slide, please. For ongoing studies, we didn't find any eligible ongoing studies when we searched for this in September. Next slide, please. So now we'll move on to guidelines and recommendations. Larry, I see your question, and I'm just going to put a pin in it for a second until we get to the discussion, if that's okay. So the American Academy of Otolaryngology Head and Neck Surgery had a position statement, and that position statement listed a lot of, many different procedures, probably most available procedures for OSA. And this table that we will build on in the next couple of slides is all of the procedures that they suggested would be recommended as part of a treatment plan or could be recommended as part of a treatment plan. So things that this position paper didn't recommend or recommended against, we don't include in this table. So this table isn't everything from their position. It's only the things that they recommended as potentially necessary. They grouped the procedures by the location, as you can see there, and each column is a different procedure. So UPPP is the main surgery that we're talking about here. Again, it's not a specific singular procedure. It's more of a family of procedures. There's tonsillectomy alone and palatal advancement. So that's removing a piece of the bone of the hard palate to move the soft tissue forward and open the airway. Radiofrequency ablation is kind of more of a technique than a specific procedure, and that's just a way of removing excess tissue. There's the lower pharynx or lower throat. We have tongue reduction, tongue suspension, and hyoid suspension. These are all similar methods to, or similar to the other procedures. These are methods to reduce or reposition tissue to widen the airway. In the larynx, there's supraglottoplasty, which is to widen the area above the epiglottis. And then there's jaw surgeries, the genioglossus advancement, which is creation of a hole in the lower jaw to pull tongue muscle forward and open the airway, and then MMA, which we described previously. Next slide, please. So then we look at our evidence-based guidelines or evidence-based recommendations. We found 6 of them from varying bodies. You can see the table layout is pretty much the same here. We have all the different procedures in the columns, and each line is a separate guideline. There's the VA Department of Defense guideline, which only looked at MMA. You can see that some of these guidelines only looked at specific procedures. Some looked at the broad range of procedures. And so it's a really mixed bag there. So the VA Department of Defense only looked at MMA and ended up recommending it. The American Academy of Sleep Medicine had general language around discussing a referral to a sleep surgeon if those criteria are met. NICE from the UK recommended tonsillectomy alone and then had some general language around referral for oropharyngeal surgery. The German Sleep Society recommended UPPP and MMA. The European Respiratory Society recommended the guidance was only limited to MMA, so it only recommended MMA. And the Japanese Respiratory Society didn't recommend any soft tissue procedures and only recommended MMA. Next slide, please. So moving on to payer policies, you can see this table layout, similar, recognizable now. And each payer is a different line in the table. So a lot of the payer policies by our read were informed by Medicare. So we can start there. That's the second line, the Medicare LCD. This Medicare policy allows for coverage of UPPP, tonsillectomy alone, tongue reduction, hyoid suspension, genioglossus advancement, and MMA. So a little bit different than the clinical guidelines that we just saw. And a lot of the coverage in Washington Medicaid and the other commercial plans really mirrors that. Washington Medicaid mirrors that pretty exactly. And for some of the other commercial plans, there's some the coverage of tonsillectomy alone wasn't quite clear to us. And in Aetna, the coverage of MMA wasn't quite clear, but otherwise the policies really mirror each other. Next slide, please. And now I will kick it over to Ariel for a discussion of the recommendation.
Thanks, Marcus. Before I start, are there any questions about just the factual data, anything that Marcus presented?
This is Mimi. I have a question. Would you be able to specify, Marcus, when you talked about sort of a review when they were looking at lowering the AHI by 20 as being sort of maybe of clinical significance or things, and you said that 2 out of the 5 studies show that. What were the interventions, or what was the study type of the two that had that large reduction? I'm just, if you have that info.
Yeah, if you can go back to the it's the OSA severity slides. Yeah, it was these ones. So the overall, there was the minimal clinically important difference of 5 events per hour, and then those authors proposed one of 20 events per hour. And so the studies that met that, I believe, and Courtney, can you check me on this? I believe it was UPPP with tonsillectomy.
And Mark, I see your hand up.
Thank you.
There we go, off mute. Marcus, I noticed on the comparison, there was 4 commercial with Aetna, Cigna, Medicaid, or Regents, and another MODA, and only 1 with Washington Medicaid. Is there a discussion about using the same commercial and Medicaid, i.e. 4 of each, or a random selection of other Medicaid states? As I know that commercial versus Medicaid can be vastly different in coverage.
It's a great question, and that's the list that we've historically used. If that no longer meets the needs of the commission, we can certainly work with HERC staff to look at different payer policies to identify what you all are looking for.
Any other questions for Marcus before I go through the discussion?
And sorry, Mimi, just to follow up on your question, Courtney, and thank you, Courtney, confirmed that it was UPPP with tonsillectomy had the significant difference.
Great, thank you.
All right, could you go move to the slide for the discussions, please?
And sorry, Ariel, just to address Larry's question, which I put a pin in the systematic reviews that we identified, we did not find any studies that looked at motor vehicle accidents in that contextual question. Thank you.
Great. Thank you. So based on all of the center's work and looking at all the evidence that you guys have all reviewed, staff are recommending that we add coverage for UPPP. And it's mainly because of, as you were pointing out, Mimi, this is the one that seemed to show the most clinical benefit. And we would add coverage for UPPP for moderate or severe sleep apnea, which is the AHI-4 of 15 or greater. And they would have to have had inadequate response or not tolerate CPAP or other appropriate non-invasive procedures. And then they would have to have evidence, basically anatomically, that the retropalatal or a combination of retropalatal and retrolingual obstruction is the cause of the sleep apnea. There is a little footnote there, as Marcus mentioned, the definition of AHI4 is actually very important. And so we would have a definition kind of going along that. I don't have a recommendation in here for DICE, which you heard Marcus discuss earlier, but that would probably be required to determine number 3. But that was not the focus of this review. That would be something that would come forward more for VBS or HERC if we decide to move forward with this. Next slide, please. So the rationale, we have low confidence that there's a clinically meaningful benefit for UPPP compared to ongoing medical management in adults with moderate to severe OSA. This benefit is in quality of life, OSA severity, and daytime sleepiness. Unfortunately, as Marcus mentioned, we don't have a lot of data on the really, really important things that we care about, like car accidents and MACE, but we have what we have. The benefits likely outweigh the moderate to confident evidence of significant serious adverse events, including death related to these procedures. And again, there is no evidence about MACE or car accidents, as we had mentioned earlier. Next slide. The second coverage indication is for tonsillectomy alone. As Marcus had discussed, UPPP typically does involve tonsillectomy. There was one study that looked at UPPP versus tonsillectomy alone and found similar clinical outcomes. And since we felt that UPPP did have a clinically significant outcome, we felt that tonsillectomy alone for adults with moderate to severe sleep apnea, as defined earlier, who don't respond to CPAP or can't tolerate it, with a tonsillar size of 3 or 4, who are otherwise not a candidate for UPPP. Essentially, this would be something that would allow the surgeon who is evaluating the patient, if they feel that a tonsillectomy alone would be sufficient. It is a less involved invasive surgery, and we thought that there was enough evidence to support it that we could recommend doing this. However, if the surgeon feels that UPPP is needed, then the tonsillectomy plus additional procedures would then be covered. Next slide, please. And the rationale for this is that there was it appears to be a similar clinically meaningful benefit from tonsillectomy compared to UPPP for adults with moderate to severe OSA. It's less invasive, and it may be appropriate for some patients who would not otherwise be a candidate for UPPP. Next slide. And our third coverage recommendation is we do not recommend coverage of MMA, or the maxillomandibular advancement, or other surgical procedures to treat obstructive sleep apnea in adults. The evidence didn't appear to support that they had a significant clinical impact. Next slide, please. Just one contextual bit of information. There are other reasons to do maxillomandibular advancement, craniofacial anomalies, kids with, syndromic syndromes where they may have extremely small jaws, but that would be a completely different situation. That wouldn't be for an adult with otherwise uncomplicated obstructive sleep apnea. And the balance of benefit and harms. There's low confidence as a clinically significant benefit in quality of life, OSA severity, and daytime sleepiness with UPPP compared to ongoing medical management in adults with moderate to severe OSA. We think this outweighs the serious adverse events related to the surgery. And there was also evidence that tonsillectomy alone resulted in similar outcomes as compared to UPPP for selected patients. But we did not feel there was sufficient data to form a balanced statement for MMA or for the other procedures. Next slide, please. Resource allocations. We acknowledge that these surgeries do involve significant cost. They are done by specialists, and they involve a invasive surgery, the risks of anesthesia, recovery time for the patient. There may be for sleep apnea, all these patients need a sleep study. That would be the case even for CPAP, which we cover. We cover sleep studies widely. We cover CPAP widely. The criteria for the coverage of UPPP would likely require coverage for drug-induced sleep endoscopy, which would add some costs. And it's not full anesthesia, but mild. There's some the mild sedation anesthesia risks, which might add costs to that procedure. Our experts indicated that some of that additional cost might be outweighed by folks who would get a DICE and found not to be a candidate, so therefore they wouldn't have a UPPP that would not be effective. So there would be a possible cost savings there. Some patients may be able to stop using their CPAP after UPPP or tonsillectomy alone, which could help with cost savings in the longer term. However, most patients would continue to need CPAP therapy after surgery. Coverage of MMA, which we are not recommending. If that coverage would be added, we would also have to cover corrective dental treatments, including orthodontia, which is currently outside of the Medicaid benefits package for adults. Next slide, please. And values and preferences. There are many patients who don't have sufficient response to CPAP or are unable to tolerate CPAP despite having a technician try to work with them with different masks or different other interventions. And they would have an insufficient response to other medical management of OSA. And they might value an intervention that would improve their quality of life and reduce their OSA symptoms. Some patients would also prefer a one-time intervention over nightly use of CPAP. Some patients would also be concerned about the significant possible adverse events that would happen with a surgery. There are a few other treatment options available for patients with moderate to severe sleep apnea who have inadequate response to or unable to tolerate CPAP. I'm sure you're all aware that the FDA just approved one of the GLP-1s, I think last week. So that might be one option, but I don't think that has really been truly kind of vetted out there in the world yet. These values and preference assessments are based on staff and expert judgment. The UPPP and MMA are only available in certain areas of the state. A general tonsillectomy, most ENTs would feel quite adequately trained to do that type of thing. UPPP and MMA would require a higher level of surgical training in general, which might limit a little bit of access. And then I see Larry asked a couple of questions. If we approve coverage of UPPP, will DICE be automatically covered? No, that would be a discussion that DICE was outside of this coverage guidance. There was no formal evaluation of DICE and its utility. So this coverage guidance would have no statements about DICE other than it might need to be done. Whether or not DICE would need to be added to the coverage benefit for patients who are being considered for UPPP would be a question for the Value-Based Benefits Subcommittee and HERC itself. There are conflicting recommendations. I think the majority of sleep surgeons would say that a DICE should be done prior, but there are some reports and some opinions in the literature that you would not necessarily have to do one. And would coverage include evaluation even if UPPP is not appropriate? So generally the evaluation would be to look for if any surgery would be appropriate. So that might be a tonsillectomy if we choose to cover that. It might be UPPP. Unfortunately, there may be some patients who undergo an evaluation and they are not candidates for any type of surgery, in which case the evaluation would still be covered. Any other questions? I see Mark's hands up, and then me. Mark and then Mimi.
Marcus, this is a question, I guess, on the studies. On the folks that undergo the surgical procedures and still need CPAP, because I know some of the criteria was do not tolerate CPAP, but then again, oftentimes afterwards they still need CPAP. What percent still need CPAP after they undergo the surgery?
That's a good question. Courtney, if you can check me on this. My impression is that it was not routinely reported in the studies, and so we don't have clear information on that data point.
And the patients who could not tolerate CPAP prior would presumably not be getting CPAP after.
Yeah.
Dr. Lamb, do you have an answer to that? I see that your hand's up.
Yeah, I mean, I guess the basic answer is that surgery is rarely curative. So to the extent that you would prescribe CPAP for any degree of sleep apnea, then yes, CPAP would still theoretically be recommended in most cases. But if you have somebody that starts from severe, like an AHI of say 30 or 40 or 50, which is not uncommon, and you get them down to an AHI of 10, you might still technically recommend CPAP for mild sleep apnea, but in most cases, that's a dramatic improvement, and those patients would be more than happy to not use their CPAP anymore, most likely. So, it's sort of, there's nuance in that question, I think.
Dr. Libby, do you want to respond to that, or before we have
Sure,
Mimi ask her
sure.
question?
A similar response, but there are patients who don't tolerate CPAP, then undergo surgery and still need CPAP. And like Dr. Lamb says, it may be less severe sleep apnea, but they actually tolerate CPAP better after surgery because there's less obstruction in the upper airway. They may need a lower pressure. So there's potential benefits there also.
That's
Okay,
true. That's right. I did forget to mention that too. I usually counsel my patients that it's possible that they may actually better tolerate their CPAP afterwards if their severity is lower and they need lower pressures. Thank you, Dr. Libby, for mentioning that.
Okay, and Ariel, I mentioned that because for the severe, the 30s or 40s, but this coverage recommendation is for the less severe of the 15s. And so I
So
guess
that would be moderate to severe.
right, and
15
that's where I was
greater.
at. That's where I was asking. I guess in that high amount, the moderate, do they still need CPAP afterwards? It sounds like they do.
I mean, I can speak from the studies. I don't have any information to directly answer your question, unfortunately.
Yeah, and we included 15 or greater because that was the study inclusion criteria for the studies that were included in this report.
Okay, thank you.
Mimi?
Yeah, thank you. So I have a question, kind of another percentage type question too, thinking about the very, very, very large number of people with sleep apnea in our state and how challenging CPAP can be. A lot of people don't tolerate it. Can you give me a sense of the number of percentage of those people, so whatever number that is, that would probably be eligible for a UPPP because of their type of obstruction? So in other words, how often is that OHA caused by this retropalatal and retrolingual obstruction?
So yeah, speaking from the studies, I don't believe we have any information to directly answer your question because we only looked for interventional studies. Courtney, if you could just check in the coverage guidance if there's anything in the background that might answer the question. If not, it's probably a question for the experts.
Yeah, and I see Dr. Lamb has his hand up.
Yeah, I mean, I will say that palatal obstruction, at least there's data from when people have reported their DICE findings and adult sleep apnea, and there's a pretty good systematic review looking at just reported DICE findings. Palatal obstruction is probably the most common source of snoring and sleep apnea in terms of just anatomic structures. About 85% of sleep apnea patients will have some degree of palatal obstruction, which is one of the reasons that the UPPP and its variations are the most common procedure that's offered for sleep apnea. So, and like tongue-based obstructions, maybe 50%. And those are probably your two most common areas of obstruction in general, with, of course, multi-level obstruction being quite common as well. But yeah, so it's roughly 85% of sleep apnea patients you could estimate as being potentially candidates for a UPPP if they're not tolerating CPAP or whatever. That's different though than, how many people are actually going to seek that out and then how many people are going to actually agree to surgery and all its, difficult recovery and so forth. Not to mention that there are relatively few people in the community that even offer some version of a UPPP. So it's not like it's a widely available type of thing.
Dr. Libby?
Yeah, I would again second Dr. Lamb and his experience on the high percentage that have the retropalatal obstruction, and UPPP is probably the first procedure to be done. I would say that we're limiting this to moderate to severe sleep apnea, and there is a very, very large group of patients who have mild sleep apnea. Some of whom tolerate and benefit from CPAP, some of whom have really pretty minor symptoms and want to just try and lose weight and do other conservative approaches, whether it's a dental appliance. Nowadays, it'll be a GLP antagonist to lose weight. So it's not as big a population as you might think from some of the statistics.
Thank you.
Other questions? Anyone want to discuss? Oh, go
I
ahead, Lily. Go
apologize,
ahead.
Ariel. I apologize. I should have raised my hand again. I guess I think what I'm wondering, Ariel, if you could comment on um, when or and probably because based on the studies and since they were moderate to severe is why you came up with the recommendation of just having the AHI-4 of 15 or greater in because it was not potentially possible to distinguish between moderate and severe. So in other words, did you consider having a higher AHI-4 number for a recommendation? In other words, only people with severe sleep apnea.
Marcus, correct me if I'm wrong, but my recollection is that there was no ability to distinguish those groups based on the studies.
Yeah, that's correct. If you want to take a look at the supplementary slide, which is optional, that's slide 72 and 73, you can see the mean AHI in the studies. It was often in the severe range, quite high in the severe range. So while the studies, had eligibility for moderate to severe, typically they enrolled folks in the more severe range, although there was even a range of AHI between those studies.
And then I'm wondering if we could ask our experts if they have, and apologies because this is not necessarily evidence-based, but if they have come across information or that is within your experience of patients who are most likely to benefit from this. In other words, have you found, and it may just be that it's more likely that people with very severe, very symptomatic sleep apnea are going to, undergo this type of procedure, but have you put any, or would you put any consideration into limiting it to potentially to the severe range? Just curious.
I'll start, and I don't have great data, but I have many years of clinical experience. And my experience has been that patients with BMIs maybe over 40 and very severe obstructive sleep apnea usually do not get to the point where they're not going to benefit, that they don't get to the point with a UPP alone or UPPP and tongue-based surgery where they don't need any treatment. So I'm very wary of those people going for a simple surgical intervention. That's my clinical experience. They end up coming back to me needing CPAP.
I agree with Dr. Libby on that one. I think to your specific question about is there a difference between moderate and severe, or does that sort of factor into who's a candidate? I don't get it. I don't think that it does really. I mean, Dr. Libby could maybe comment more, but my sense of it is that anybody that has at least moderate sleep apnea, they're going to be symptomatic and they're going to be at risk for sort of the downstream sequelae of sleep apnea. And yes, more severe might be more at risk, but I don't know that you can meaningfully distinguish those in terms of risk of sequelae and impact on quality of life based on moderate to severe, and therefore say that they're more like some more severe folks it's more meaningful to do a UPPP or whatever on them. That's not really how I look at it, and I think that that's the literature in terms of impact and severity. It would probably back me up on that, but maybe Dr. Libby can comment more on that. But back to your Yeah, I agree with what his comment though. I think the main thing really is if they are very obese, I don't think they're great surgical candidates for any kind of surgery, frankly, because they're just less likely to have a significant impact from it. And that includes hypoglossal nerve stimulation as well, but that's not what we're talking about today. So yeah, for those folks, I just tell them they need to go lose weight, or if they can't do that and they're still really struggling and and it's a major issue, then I actually offer them a trach as maybe the only option that can adequately treat really severe sleep apnea in that population. So very
Thank you. That was really helpful. I appreciate that.
Yeah, I don't know that anybody has taken me up on that.
I see Mark's hand up and Larry's.
I guess for what it's worth, just looking at prevalence of AHI greater than 15, in the European study, nearly 50% of OSA in men have AHI greater than 15 and 30 to 40% in the US. So I think this is going to be a pretty large population that this could apply to. And I guess that's my question or concern, is this opens up this procedure to upwards of between 30 and 50% of men and 25% of women with obstructive sleep apnea would have AHIs greater than 15.
Mark, do you know if that was AHI 3 or AHI 4, which AHI measure they looked at?
That I don't have that.
3 is far more liberal than 4. That's why Medicare and OHA and a lot of places are using AHI 4.
Yeah,
Okay.
if you send me the link, I can take a look at it. If you have other thoughts, I don't to keep the
Okay.
discussion going.
And that's what I just want to clarify is the prevalence of the population. Okay. I'll send you the link.
Dr. Lamb, do you have information on that?
Well, I mean, not on that specific question, no. But I was just going to comment. I mean, I think to put it in context, I mean, anyone that's getting diagnosed with sleep apnea is going to be prescribed CPAP first. And while they may then seek out surgery if they're not tolerating the CPAP for some reason. I mean, that's why I think that's in the actual recommendation, right? Is that they're not tolerating CPAP. So it's not like everyone who's diagnosed with sleep apnea is suddenly going to seek out surgery, right? In fact, in my experience, it's very rare that sleep medicine docs who prescribe the CPAP will actually, I mean, most of the time they don't like sending somebody to go consider surgery. So it's not like it will suddenly open the floodgates, I don't think, any more than the hypoglossal nerve stimulator. I mean, that has become much more popular, but it's still not super widespread, even in places that for people for whom it's approved, like, obviously not covered by OHP yet. But so,
and Dr. Lamb, do you have a sense in Oregon and close by catchment area, how many ENTs are doing UPPP?
Not many from what I have seen, because yeah, I mean, I trained one of my colleagues to do it. There's no one else in my department that's doing it. I have seen some people in clinic that have had a much earlier version of a UPPP done, like in the 90s, but nothing recent. And many of those people had, not great outcomes, but that's again reflecting that the techniques have evolved over time. I think that there was some initial enthusiasm when the type of surgery first became sort of, I guess, more well known in the 90s, and then that's when a lot of the early sort of outcome studies were published about this, and then a lot of people were trying it, and then they found that they weren't getting good results with it, and I think a lot of those people just stopped. And so now there's like hardly anything in the community that I know of where people are really doing this. The newer techniques have better outcomes, but they're a little more challenging to do, and so that's why you don't have many people doing it.
Thank you. Larry, you had your hand raised?
Yeah, a couple of questions. Can you hear me okay?
Yes.
Great. So a couple of things. One is I was just looking at a paper from September of 2024, Journal of Clinical Medicine, and it mentioned nasal surgery in combination with UPPP. The are we when we are looking at UPPP in the studies that I've seen that we're looking at from that Marcus and his team have looked at, was nasal surgery mentioned in any of those? And do our experts think that nasal surgery is that typically a part of the procedure nowadays? And is that helpful?
So in the studies that were eligible for the scope, we didn't, we did not, correct me if I'm wrong, research team, but we did not find nasal surgery as part of those. If there was a study that looked at UPPP plus nasal surgery, we would have included that if it was otherwise eligible. We didn't exclude a study just for having nasal surgery as
Okay.
part of it.
Okay.
Dr.
Just
Libby?
one last point was if there was a study only of nasal surgery alone, that was considered out of scope by the HERC. So that was not included. Yeah.
Okay. I have another question, and that is the very first treatment for people with OSA who are heavy is fitness improvement and weight loss. And so I'm looking at possibility of bariatric surgery. Do our experts have any thoughts about bariatric surgery and improvement of sleep apnea to the degree where someone may not need CPAP or their CPAP need may be significantly less?
And Larry, we cover bariatric surgery, and one of the indications would be obesity and the complication of sleep apnea. So that is something that's already covered under OHP.
Okay.
Dr. Libby?
Oh, I was just going to mention that nasal surgery by itself is not curative for sleep apnea, but it is occasionally indicated to help someone tolerate CPAP if they have major nasal obstruction. And Dr. Lamb knows a lot more about that than I do. But I've had many patients who couldn't tolerate CPAP because of deviated septums, polyps, whatever. And with surgery, they were able to tolerate CPAP.
Great. So back to Mark's point of if this is covered, would we be seeing a lot more patients? What I'm wondering is if improved fitness and weight loss is the first line treatment, I'm just wondering what portion, and we can't know, what portion of those patients who have OSA and are heavy would benefit from that to a degree that their sleep apnea would be significantly less severe. Sorry, I pose questions that are we can't answer.
Yeah, that was outside of the scope of what we asked this when we did the bariatric surgery review years ago. It did improve sleep apnea, but that wasn't looked at specifically in this area.
Thank you.
Dr. Lamb?
Yeah, I mean, so I'm not super familiar with the data on bariatric surgery specifically, but my impression is that you might get improvement, even significant improvement, if there's really dramatic weight loss, but they're still a good chance, just like with any other type of surgery, that they're going to have persistent sleep apnea, perhaps at a lower severity. And that still has its own benefits, and certainly they may better tolerate their CPAP for the same reasons that we talked about before, if they need lower pressures, et cetera. And I have occasionally referred some of my patients that I have seen for bariatric surgery because I felt like that was their best, without me doing anything to them, because I felt like that was their best option up front. And I have seen it be successful in a couple of folks. Although I will say I saw one patient back recently that had gone through all the bariatric surgery and still struggled to maintain that weight loss. And it was only after she got on a GLP-1 that she finally was able to achieve and maintain significant weight loss. And she is actually still has sleep apnea. And so now we're talking about actually doing, some type of sleep surgery on top of all of that. But anyway, I'm sorry. I guess, oh, and the nasal surgery thing. Yeah, I totally agree with Dr. Libby. I think it's most of the time, I mean, that is commonly offered in the community. I think that's because that is considered a bread and butter procedure that any general otolaryngologist can do and does quite routinely. But it's almost always offered as a bridge to CPAP, facilitating CPAP and not as a meant to sort of by itself treat sleep apnea or and to a significant degree.
Great, thank you.
Dr. Libby, did you have your hand up?
Oh, quickly, years ago, we had poorly controlled studies that showed if someone could lose weight, they showed benefit at about a 10% weight loss in terms of their AHI. If they could get up to 20 to 25% weight loss, a lot of them were back down to near normal. But how many patients can do that nowadays? Yeah, maybe with the new drugs. But back then, I think it's less than 5% of our patients, well under 5% can lose those sorts of weights and keep it off.
Right. All right. It sounds like we've kind of gone through most of the general questions. Do we want to talk about the specific recommendations and whether or not you all agree with them or want to change anything in them? So this would be the UPPP with an AHI of 15 or greater. I guess we could talk about the 15 number, although I'm not sure that we could, based on the literature, give you a different cutoff. And then again, not tolerate or not respond adequately to CPAP, and then have some sort of anatomic evidence that would indicate the surgery would be effective.
And just as a reminder for everybody, since we're on a low frequency item, the next step for this would be to post it for public comment for 30 days. And so this would then come back to you again after getting those comments, and there would be another chance to revise. So keep in mind the process as you can make changes, but before you put it out to comment, but there'll also be another chance to respond to comments.
And Ariel, quick question on the AHI 3 verse 4 on the PAs that we receive. Rarely do they say if it's a 3 or a 4. Are most AHIs at sleep studies now 4 versus the old 3? I'm not familiar since we don't.
Medicare requires it to be 4, so I think most report 4. I've actually seen reports with both 3 and 4. You can always ask for the specific, whether it's a 30% reduction or a 40% reduction, or I'm sorry, a 30% oxygen desaturation versus 4%. You can ask for that from the sleep specialist. It seems like a little tiny thing, but it actually makes a huge difference.
Right, that's what I was asking. I just haven't seen it that specific. But Lewis, you're saying that they're all 4 nowadays. Is that what you're saying?
Yes, with the proviso that I've been retired for 2.5 years. But before that, since maybe 2010, everyone transitioned, at least in the Portland area that I'm aware of, to the 4% desaturation as being the standard. And that's what the insurance companies wanted. That's what Medicare wanted. But Ariel's correct. The formal report, maybe not the dictated report, but the formal report in the background should define what AHI is.
Thank you.
Yeah, they always define it, and most of the time if they report the 3, it's they're reporting both. So that I've seen.
I'm not hearing a lot of concerns about the first recommendation. So it sounds like this is something we're comfortable putting out. And we can move on to the second. And this is a very similar, but it's tonsillectomy alone, and it would be rather than having, so the first 2 criteria would be the same. The third criteria, rather than being, needing the anatomy that UPPP would respond to, they would have to have a 3 or 4 tonsil size rating, and they would have to not be a candidate for UPPP. Any concerns about this recommendation?
Just a clarification, Ariel, on the inadequate response to CPAP. What is our definition of inadequate response? Is it a follow-up sleep study? Is it doesn't fit? I'm just
Marcus, is there a definition in the literature for inadequate response? Dr. Lamb is shaking his head.
Yeah, we saw a mixture, but often the one that I remember seeing was that OSA did not resolve, so the AHI continued to be elevated. That was when stated. That was typically the inadequate response.
And presumably the patient would continue to be symptomatic.
Yeah, I mean, presumably.
Does that inadequate response include the patient not tolerating the CPAP?
That is the second portion of that sentence.
Okay.
Cannot tolerate CPAP.
Okay, thank you.
and that's what we commonly see is they can't tolerate it. I have yet to see an inadequate response as a reason for not using it. And I only mention that because it's very infrequently a reason not to use it, the inadequate response. I'm fine with it though.
Okay.
Yeah,
Any
I was
other
gonna say I have had patients that have reported to me that they are still very symptomatic, even when they continue to struggle to use their CPAP, and um, that's that's kind of how I think of it as an inadequate response when they're clearly still snoring and also still having daytime sleepiness, etc. But I don't think there's any formal definition for that. Dr. Libby can maybe correct
He's
me if
shaking
I'm
his head.
thinking about that.
I agree.
Is there a need to take into account adherence into that?
Presumably, if you can't tolerate, you would not be adherent.
Correct.
Yeah, I
But-
mean, I do have some patients that come to me that have been using their CPAP very successfully for 10 or 15 years or whatever, and clearly are getting benefit from it. And they'll say that they can't not use it, but they hate it and they have lifestyle reasons that they want to try and get rid of it. And I always tell those folks, I'm like, there's not much I can do for you because no insurance is going to cover surgery to get you off CPAP just so that you can go camping more or whatever. Unfortunately, but I have had that awkward conversation a number of times, but that's clearly a situation where they do not meet this criterion, right?
Yeah, so I guess then I was saying inadequate response to CPAP despite adhering to the therapy.
We could edit that. We could put that in there if people want us, if the group agrees.
Or is it binary? Is it one or the other, or could it be both? And because the question is, are people non-adherent for reasons that we are not clear about? I mean, I don't think we have a set of criteria that says this is what makes you non-adherent. Some people just don't use them and they don't explain why.
I mean, there's very specific criteria for what adherence means. So that is available, but I think the way that it is written as cannot tolerate or don't have a sufficient clinical response, I think that should be sufficient. I don't know. It seems like that kind of covers both options, people who can't tolerate it, and then those who it's not effective.
Yeah, I would agree with that. I think the wording is good as is.
Any other comments on our second recommendation? Should we move on to the third? And this is where we are not recommending mandibular advancement or other surgical procedures for sleep apnea. Does anyone not agree with that? Would anyone want to argue for coverage or?
I would just note we did receive some comments from Stacy Geisler, our oral surgeon, saying that this is a fairly established surgery, but the whatever the evidence base is for it did not meet our inclusion criteria. I think we saw that a number of other payers are covering it, so we may get some comments about this one.
Yeah, I kind of, that's kind of how I feel, that there is, a reasonable evidence base in my mind, but maybe just not of the high enough level to, qualify for the review that was done. I do think of this as, like there are many patients when I do the DICE where I don't think that what I can offer them in terms of soft tissue surgeries is going to be successful. And then I might send them to go get an MMA instead because, that might be the only option besides something like a trach or whatever that has a chance at success for them. So, but I understand if there's, the evidence, the strict evidence isn't there necessarily. Dr. Levy, I'm sorry.
I would, part of me agrees with the head and neck surgeons who say there is a evidence base, but it's not a recent evidence base and it's not controlled in any fashion. It's very anecdotal from the 80s and 90s, mainly from Stanford, I think. The other problem with it is it requires extensive dental reconstructive processes that probably cost tens of thousands of dollars. It is not covered by Medicaid in our state. So I agree with the statement.
Yeah, it's certainly not for the faint of heart, and it is a whole process, no question.
Okay, so it sounds like folks are comfortable with our current coverage guidance as it is to go out for public comment. Jason, Linnea, do we need a vote of any type?
Yeah, we would need the subcommittee to vote to put it out for public comment.
Yeah, we do need that affirmation. So, Jessica, can we go through the verbal roll call?
Well, we would need
Sorry, was there a motion?
Oh, we need a motion first. You're right. Sorry.
I make a motion to accept these recommendations to put out for public comment.
Is there a second?
I second that motion.
Thank you. Now we can go to vote. Thank you, Jessica.
All right. Linnea Lindsay,
Agree.
Mimi McDonald,
Agree.
Mark Buckles,
Agree.
Deb Espicente,
Agree.
Abigail Khan,
Agree.
Larry Lyon,
Aye.
Kat Livingston,
Agree.
Judy Richardson.
Yes, I agree.
Sounds like it's unanimous. Motion
Great.
passes.
Thank you, everybody. I appreciate that and really appreciate the very thorough review. That we really appreciate here is Evidence-Based Guidelines Subcommittee. So, Jason, do we move from here to the orientation? I know we're behind time.
Yes, please. I'll try to catch us up a little bit. I will also acknowledge that we put way more on this agenda than I expect to get through today. So while Liz is pulling that up, this is a little bit of new work for this subcommittee. And for those of you on HERC, you will be somewhat familiar with it from last month. But it's a little bit of a different mindset than our deep dive evidence reviews. For many of the topics today, you won't see an evidence review. They're just be based on clinical judgment. The reason we're putting out all this volume, we're not expecting to make decisions on all these today. What we'd like to do is approve the easy ones that everybody agrees on. If anybody sees something that looks off or needs more research, basically just raise your hand and we'll take it back and bring it back at a future date with more research. So this is sort of a way of identifying, getting all your great minds out there to, what do we need to dive deeper into? What does everybody agree on? So if there's any question, please don't hesitate to speak up and ask Ariel, and she will flag it for a more in-depth review. And you can even say, what in particular your question or concern is so that she can focus that. That said, this group has not also had I think I've mentioned the benefit update project, but I haven't done a full orientation. Again, many of you at HERC have had multiple presentations on this, but I want to run through this at least briefly to orient you all. Please feel free to stop me along the way. I will go through it fairly quickly. I may answer that I'll get to that later, but I think it would be productive to interrupt me if you need to, what I'm saying is not computing or not making sense to you. So let's go to the next slide. So this is some background on this project. So the Centers for Medicare and Medicaid Services notified Oregon back in 2020, what was it? 2020, a couple of years ago. Then starting 1/1/2027, I think it was 2022, Oregon will no longer have access to the federal waiver of law that permitted the use of the prioritized list, which is our main work product that we don't deal with in this subcommittee, but the HERC, that's the HERC's main work product. The original intent of the prioritized list was to maximize the number of people covered by being strategic about the services covered. However, since 2012, the prioritized list has not been used as a budget tool. There's been an agreement with CMS that the funding line would not move. And even long before that, other steps were necessary to balance the budget. And those were differed over the years, and I won't get into that right now. Right now, unlike in the late 80s when the prioritized list was conceived, 97% of people in Oregon have health coverage, which is a record high. Under the prioritized list, not all mandatory benefits were covered. So the mandatory benefits we'll get to in a minute are things like physician services, hospital services, laboratory and x-ray services. Other services are classified as optional for reasons that have more to do with history than their importance. One of the features of the prioritized list was that it ranked things on importance regardless of what kind of provider did them or what setting they were performed in. But one of the criticisms was not all the mandatory Medicaid benefits are covered. This transition is an opportunity to expand coverage to include some additional medically necessary services, and you'll see some of those recommended today. HERC will continue to provide guidance on which services are considered medically necessary and under which conditions through our public evidence-based process with which you are all familiar. So the plan is for HERC to continue to make similar kinds of decisions, just not express them in a prioritized list. The HERC mechanisms to prevent undue influence by interested parties will remain in place. Next slide. The center, again, this is review the operational elements of the prioritized list structure in the HERC will continue. Our evidence review, our code pairing files, our medical necessity guidance, guideline notes will continue. HERC's public process will continue. We're not planning on changing all those things. They seem to be working fairly well, serving Oregonians. We will be making some changes to how things are expressed. Our values of transparency, stewardship, equity, evidence will continue to guide decision. And federal law, even without the waiver, federal law does allow limitations based on medical necessity and utilization management. As you saw in the presentation about the sleep apnea surgeries, other states do have limitations on those surgeries and make choices about what they cover. OHP will still be able to do that. It would just be a new context. We do expect some increased costs, and money will need to be come up with by the legislature to pay for that cost. That won't be our task here. There is no plan at OHA to reduce the eligible population or benefits. Hopefully that is not necessary. Background, just why are we doing this? Again, CMS heard concerns during that waiver renewal that not all the mandatory services are covered. The members might not have access to full appeal rights due to denials below the line. And that's an operational thing. That's not for our fee-for-service program. That's not our concern here. Again, the funding line hasn't moved since 2012. Our uninsured rate is low. Let's go on to the next slide. So the bottom line, the waiver will end. Our state plan amendment, which is our agreement with federal officials, our medical necessity policy, our utilization management will continue to be used to manage the benefit. State plan, which we have today, will continue to define benefits at a high level. We're planning on doing some streamlining and bringing it up to date, but not planning major changes for that. HERC and the existing administrative rules that you may be familiar with if you work with them will continue to provide the medical necessity policy as much as they do today. CCOs also have their own criteria that for things that HERC doesn't rule on. Some of them use external resources to guide coverage of things like imaging. That can continue. That's the plan at this point. Medically necessary state plan services. So if they're in the scope of that state plan and they're medically necessary, the idea is to cover them. Some services, again, will not be covered if they're not medically necessary, if they're experimental, not safe and effective. We do expect some increase in scope. Next slide. We did hear feedback. I'm not going to read all these in these contexts. They're the kinds of things you all probably hear frequently when we have public testimony. It will be a change for our system. People need to be informed. Next slide. Concerns about not being able to access care. We know we have shortages of providers in different areas of the state, especially in certain specialties. That will be addressed, but not in this project. Questions about medical necessity. We're going to get into that a little bit later. Education and outreach, obviously not our task at this subcommittee, and the appeals process will not be our task here. So let's scan forward. Next slide. CCOs raised some concerns. I think we've been addressing some of these, so I won't spend a lot of time on this, but there they are. Systems changes, costs, decision-making might change. Next slide. Here are some of the responses. I think I've gone over most of this. One thing I want to highlight is pharmacy and dental. For medications, there will be some medication. We don't review a lot of medications at HERC because those are largely done by the pharmacy and therapeutics committees of the fee-for-service program and CCOs. Some medications are currently being denied based on the funding level. So if you have a medication that's subject to prior authorization and the condition for which it's prescribed is unfunded, it can be denied. That ability will end. Though, just like for other medications, prior authorization and preferred drugs can be used. Dental coverage is unlikely to change through this project. The more operational questions are potential topics for discussion during the upcoming BUP-CCO work group. So I think we kicked that off a couple weeks ago. Those are some of the things we're getting questions about from our CCOs, and we'll be working with them in those work groups. Not here. Go ahead. Let's dive into medical necessity and appropriateness. So we've had this methodology for ranking services based on their impact on health, their impact to the population, the effectiveness of the treatment. That will all go away as a North Star because we won't need to rank services. We won't need to say whether setting your broken leg is a more important service than treating your hepatitis C. That problem will go away. Those are both important. They need to be treated. Medical necessity and medical appropriateness are the concepts that guide that decision. Go ahead, next slide. So medical necessity, if you have health insurance, you've probably heard it. Medical necessity is a concept that's used universally in the US, but it's not defined in federal law. It's used in different ways in different places. So we're going to talk about our context here today. Medicaid can only pay for medically necessary services, and each state has its own definition. And the plan is for those definitions to be created largely by HERC. So the state would delegate its authority to HERC to make the medical necessity decisions. For OHP, they're defined in administrative rule. We'll look at those in more detail in a moment. And HERC can develop code pairs and criteria, which are guidelines to define what is medically necessary for OHP. In addition, there are other agency rules and policies that can apply. Next slide. So here's some of the highlights. I didn't include the whole rule here, but we want to include services that prevent or detect disease to prevent illness or impairment, diagnosis and treatment of acute illnesses, including emergencies, diagnosis and treatment of chronic illnesses to prevent complications, improving function and independence in activities of daily living, helping children achieve age-appropriate development. So all of those things are incorporated in those definitions. They're also very much the values I've seen expressed in this subcommittee and at the HERC for the last going on 15 years. So I don't expect the decision rubric to have to change. What's changing is it won't be about prioritization. It'll just be a, should we cover this or not? And if so, under what circumstances? Go ahead. So examples include services are ineffective, unproven, harmful, more costly than an equally effective and readily available alternative, experimental, investigational, cosmetic, solely for the preference or convenience of the member or provider. And then we got into that a little bit about the CPAPs a few minutes ago. Next slide. As with all other states, OHP does not cover all medically necessary services. Yes, there are some medically necessary services that people want, that I use, that many of you use, that aren't covered by our Medicaid program. Infertility services, root canals and crowns for adults, drugs for sexual dysfunction, hair growth treatments, eyeglasses, calling those out. And so those will continue to be outside of the benefit package. Those decisions will not be made so much at HERC, although HERC may help set some parameters for those. Again, they may be medically necessary and very important for many people. There's just not OHP benefits. Next slide. This, I'll give credit to Marcus Bachhuber for developing this. This is sort of a window diagram. So is the service in the OHP benefit package at all? That's the question on the left side there. If not, it's just not covered. And again, eyeglasses, infertility services fall into those categories, things like that. In other cases, if it is in the benefit package, there's still another question of whether it's medically necessary. And again, HERC will be creating policies to determine that. And that's what we'll start the process of doing today. Go ahead. Medical necessity and current coverage will be operationalized mainly through code pairings and guideline notes. We're calling them code pairing files or code pairing groups. They'll look very much like our prioritized list line numbers. Again, for our purposes today, the focus is, should we be covering them or not? And the services, are they medically necessary or not? You see some examples there. Psychotherapy is a procedure code that can be billed. It is medically necessary for depression. If you have an abscess, that's a different diagnosis. Psychotherapy probably would not be the best treatment for that. Incision and drainage, on the other hand, would be. So that's what code pairing is. Claims without a covered code pairing will generally be denied. Our guideline notes, which often resemble the criteria in our coverage guidances that we do here will provide more detail when needed to determine medical necessity. And HERC, with assistance from staff, would create those in much the same way that the prioritized list is created today. Again, there are also some other agency rules and policies that would continue to apply. Next slide.
Real brief, sorry, Jason. Larry asked about eyeglasses for kids, and so I think this could be a good mention for PSDT.
Thank you. Yes, for children up to age 21, up to their 21st birthday, and participants in the Young Adults with Special Healthcare Needs program, eyeglasses, crowns, root canals, any Medicaid eligible service that is medically necessary is covered. So we're talking mostly about adults here. Thank you for that question. And yes, they are important for development. So current reality is that even for diagnoses below the funding line, for example, tension headaches are below the funding line today. Office visits, diagnostic testing, and preferred medications that aren't prior authorized are covered. None of that will change. We don't need to talk about that. What we do need to talk about is if something else is needed. And you can see the examples there of common colds, diagnostic services, medications, office visits, although an expensive medication might be denied for one of those conditions. Those are the ground we walk on. We don't need to spend a lot of time talking on. What we do need to look at is, of those conditions in the unfunded region, if something else is needed beyond the office visits, diagnostic testing, and medication, let's talk about it and whether we need medical necessity criteria about that or whether it is medically necessary. Next slide. New reality of OHP. So again, those services will be covered. Durable medical equipment is another thing that is covered if the diagnosis is covered today, is funded. So if we add a service, again, something like fibromyalgia is currently unfunded. And so if somebody would request some sort of durable medical equipment for that, it could be denied because it's for fibromyalgia, not for any other reason. In the future, it'll need to be considered with similar criteria as any other condition. Anesthesia, same deal. Some additional services will be added based on HERC discussion. Many of these are being paid by exception through the comorbidity rule or EPSDT, which we just spoke about a moment ago for the children under 21 and the young adults with special health care needs. Next slide. These rules need consistent interpretation, so our guidance at OHA is very similar to our guidance today. CCOs must cover things identified as medically necessary as they apply to the member's circumstances. CCOs can deny things that are not medically necessary. Where HERC has made clear policies, CCOs will be able to rely on it to support denials and uphold appeals. CCOs have discretion to make exceptions, as they do today. And where HERC is ambiguous or silent, CCOs can use medical judgment and external resources because people are more complicated than can be expressed by medical codes or any policy that we write. This is a review slide. I'll just let you absorb that. Next slide. Now we're going to talk about what this will look like. Next slide. This very complicated diagram with the pitchfork in yellow. The pitchfork is our work. You see the left side is the unfunded region of the prioritized list. What you're going to see today in a minute is a bunch of those services and conditions, and you're going to sort them. Some of the sorting has already been done for you. They're not covered in the state plan. In most cases, they are, though, and you need to choose, are they medically necessary or not? So, next slide. Here's an example. You can see here a line from the prioritized list on tobacco dependence, which I picked because it doesn't have very many codes on it. Code group will look a lot like a prioritized list line does today. It'll just be called something else. The guideline notes will be edited with conforming changes in the funded region. However, in the unfunded region, we sometimes will need to make some more substantial changes, and you'll see examples of that today. Next slide. Again, this is what a recommendation will look like. You won't see allergies today, but you'll see some other things. Go ahead. And here's an example guideline, the new guideline for allergy testing that was considered at one point. I think Ariel has been editing this since then, and we'll see what BBBS does with it next month. Or maybe that's in May. Next slide. Again, that's another potential coverage guideline. You notice instead of guideline notes, we're calling them coverage guidelines. Just we've had confusion about whether a guideline note is a clinical practice guideline or a coverage guideline. They're coverage guidelines. They're not a full comprehensive guide of how to treat a patient. Next slide. Here are some examples that are of services that are currently not medically necessary. Platelet-rich plasma, epidural steroid injections for back pain, excision of the lingual frenum for tongue tie, spinal fusion for a person without nerve impairment. Those are not medically necessary today. Sorry, and some of those are in the unfunded region today. Most of them don't pair in the funded region. Some services are just out of the benefit. Infertility, again, GLP-1s, dental crowns, root canals, eyeglasses for adults. Next slide. No plans to change the medical necessity and medical appropriateness ruling. Again, those requirements I went over earlier about how CCOs apply our policy. Next slide. This is our plan at OHA. There will be a bill in the legislature, and we'll see how that evolves, if it evolves. But our plan at OHA, and I hope it's a good one, is for HERC to continue to be an independent governor-appointed commission confirmed by the Senate, and to continue to use our evidence-based, transparent process, balancing participation between members, CCOs, providers, and other parties. We'll still consider equity in decision-making, and our deliverables will evolve with only necessary format and language changes, as you saw a few minutes ago. Next slide. All right, diving in just a little bit more. I'm almost done here, and then we'll get into the actual topics. Next slide. So we will be hiring an additional medical director. I'm hoping to do that tomorrow if I'm lucky. And medical outreach to specialists. We started doing that in November, and this week Ariel, I don't think she got up out of her seat, but there was a little chair dance that she finished the last issue summary. So we are getting that stuff out there. I just published during this meeting, actually, another set of those materials for the March HERC and BBBS. And we'll have more for you all in April and then again in May. And that will be the complete set of recommendations, given, of course, that some of those will not be dealt with completely and we'll need to come back to later meetings. Our goal is to get through all of them by the end of 2025. So fasten your seatbelts. That's why we've enlisted you all to help with that process. And again, we'll be coordinating with actuaries and budget to make sure there's funding allocated. Next slide. We have published a tracker on our homepage. Daphne helped me develop that. It's searchable. We're updating it every week or two. And we are publishing our meeting materials. They have a lot of detailed information. We'll have previews of our policy deliverables later this year, and we'll do dual maintenance of the list and new deliverables throughout 2026, so that we'll be working on what's going to be effective in 2027, even while we're updating things for the year of 2026. Okay, next slide. We will also be consolidating some lines. For example, I think there's some examples that multiple skin conditions, multiple ophthalmology lines. There's no reason to separate them because we don't need to prioritize them. So we'll simplify things in that way. If you all think we simplify too much, that's an opportunity for you to have your voice heard and your impact shown. Some items aren't controversial. We might remove them from the funded region sooner if they benefit patients, if we can do that with funding. Consolidation of multiple lines will be vetted by you all, and final decisions confirmed by HERC. Next slide. Is that the end? All right, that's the end. So with that, I will turn it over. Well, first, let me open it up for questions. I know that was a lot of information, especially for those of you not on HERC.
And just to summarize for you all, the more things change, the more they stay the same. So a lot of what HERC has been doing for years is doing code pairing, which is medical necessity. We're going to continue that. We're just kind of changing the names. But I see Mark and Larry. So Mark?
Hey, Jason, quick question. I heard that it is separated from funding and it will be the legislature's job to fund it. But then I heard discussions about funding and actuaries. I guess my question is, in the past, we were connected to the funding line. Are we entirely separate from funding and it is all medically necessary, or do we still look at some degree of cost and funding?
Yeah.
It seems murky.
So under federal law, there are two reasons we can limit services. One is medical necessity, the other is utilization management. We can't just say it costs too much. We can't, if it's a mandatory Medicaid service or it's in the scope of the state plan. That said, we may put stricter criteria around a more expensive service, especially if there is a better alternative, or it is a relatively less important health condition. Those get into the nuanced decision. So we'd be completely divorced from costs? No, but I will be coordinating with our actuaries to make sure that, if a new technology comes out or a new service, has better evidence and gets approved, that the funding can become available so that that can be implemented in a timely fashion.
And that's one of the reasons we've sort of hijacked you all, EBJS, and doing all of this work. We have, as staff, pledged that all the materials will be published and available for the public to look at by April, and all of the decisions will be made by December, so that the actuaries have a full year to come up with an actuarial sound rates for the CCOs.
Go to the legislature for budget if that's necessary. And I think the plan is to do that. So we won't be juggling, we'll be determining whether it's clinically, medically necessary and appropriate or not. We won't be responsible for coming up with the funding. That said, I will be coordinating with the rest of the agency because services do need to be paid for. Larry.
Oh, go ahead. Go ahead.
Oh, go ahead, Ariel.
I was just going to say, so the funding line has always been a little bit of a fiction. We pay for tons of stuff below the funding line. We pay for so many things. If we pay for fibromyalgia, if you're going to your doctor once a month for your fibromyalgia diagnosis and you're getting gabapentin and there's no PA on it, we've been paying for that for years. So this is going to make that a little bit more obvious to both the public and providers. Our main question is for fibromyalgia or for whatever, is there other things? Should we also be paying for acupuncture and PT or something like that? So that's kind of where the work is here.
Yeah, thank you, Ariel. All right, go ahead, Larry.
Yeah, I've been looking on the meeting materials on the PDF page 7, under medically appropriate and medically necessary. I'm still having a little difficulty understanding something that is medically necessary but not covered. So for instance,
medical necessity is kind of a legal business term. So when you think of something being medically necessary, you have a heart attack, it's medically necessary that you have a cardiac catheterization to open the blood vessels, you get medications. That seems to make sense to most people. But we can say, for example, bunions may only be medically necessary to fix if you have diabetes or peripheral vascular disease and you have an ulcer on your bunion. That's the only time that we think, we being the HERC, feel it's medically necessary. Whereas somebody else might say, it hurts my foot, and therefore it's medically necessary to treat. So
Okay, I'm a little confused because it sounded like your definition for the standard for medically necessary moved from legal to medical. There was a switch
Yeah,
there.
yeah, let me try to sort that out. So if you could bring that slide up, Liz, with the little Marcus slide with the diagram there, I think hitting that one more time might help. So yes, there are services that are medically necessary, but they're not covered. And that's exactly what we're talking about with the dental crowns and root canals for adults and the eyeglasses. Is that addressing what you're talking about?
Well, it gets to what I'm talking about because on page 7, under medically necessary and section C, it says the client's or member's ability to attain, maintain, or regain independence and self-care, ability to perform activities of
Yeah,
daily living or improve health status. And so, for instance, if someone is legally blind, okay, and there is something that we want them to be as independent as possible.
right.
If someone's vision is so poor that, for instance, they can't take care of themselves at home or drive a car to be able to get to
Yeah.
work. Okay, so I
Well,
understand
that is
there's
exactly the dilemma. I think we all would agree
okay.
that, and even for less severe cases, to be able to read and work and read the news, whatever, read a novel, that's a really important service. Unfortunately, it's not in the benefit package, and so it's sort of out of bounds.
Let me connect the dots a little bit more. Okay, so to me, health is a utilitarian value or state. And so if someone is able to take care of themselves and be independent, okay, then they are able to contribute. I'm speaking in broad brushes, but they're able to take care of themselves, take care of their family, be independent, make contributions to society. And so where do you make that cutoff is I think is
Yeah,
I think it might be helpful to just kind of dive in a little bit
yeah. Let's
into.
dive in a little bit. I guess the short version is that those are outside of our scope. Those are legislative funding decisions for the governor's budget and the legislature to work out. And they are important for the reasons you say, but they're also balancing that against school teachers, roads, bridges,
all
other.
of which are important.
Exactly. So let's go. Is there any other questions before we dive in? All right, get ready, folks.
So, and just to warn you all, it with other groups that I've worked with this, it seems like the first topic takes a long time, and then things kind of start getting more. I think people just start. It kind of starts to gel. So don't panic if we don't get through everything. We really don't expect you to. If you are used to the VBBS and HERC materials, you may notice that these materials look different. We are kind of putting everything up front. So there are things that staff have identified that are possible major changes. They may be something that might be um, recommended by an expert that the staff has some questions about and wants to talk about. They may be some things that may be adding some costs. They may just be some more informational that these things are going to be suggested for addition and do you agree? So the first topic how I did this was I took all of the fund lines below the funding line and I grouped them into specialties, and then I met with specialists in those areas to help me devise this. So there were a couple of uh, actually some of the OHSU lovely gynecologists worked with me on this. So there's some expert input, but this is all it's all my work, so don't blame any of them. But there was expert input. And we went through the lines that are currently non-funded and went through and said, where should we possibly so going back, the default, if we decide that all something needs, like for example, Mittelschmerz, which is a mild pain that happens when a woman ovulates at times. It doesn't need anything besides a patient may come into their doctor worried about it. The doctor explains it to them. They go away. That visit is covered. No big deal. We're going to continue to do that. We're calling that evaluation and medical management. So that's kind of the default. Everything gets into the bucket of evaluation and medical management. Some things are going to get into other buckets like hysterectomy. Many things above the funding line already have hysterectomy as a treatment. There's some things below the funding line that are paired with hysterectomy that our gynecology colleagues feel that we should actually be covering because we're already kind of covering them, usually with a different diagnosis code, or providers have gotten very well trained in our system. So the main things to discuss here, there's some polyps and dysplasias and cysts and sort of more minor things of the vagina and vulva, the outer female genitalia, that experts thought we should cover treatment. We also have guidelines for chronic pelvic pain and dysmenorrhea that would allow hysterectomy. The gynecology folks that I spoke with said, these are probably already, we're probably giving a diagnosis like endometriosis or something for this anyway. They didn't feel like this would be a huge expansion, and they did feel that these were, the current guidelines were appropriate. So that's one of the things that we need to talk about here. Many other things are just going to be in this lump of office visits, maybe a pelvic ultrasound, maybe some medications like ibuprofen or birth control pills or whatever. So Dr. Maria Rodriguez was the main consultant, but she consulted with her entire group on a lot of these questions. So it's kind of a group effort. So you won't see an evidence review. This is really just kind of when there was a question specifically that kind of came up during the review, there you might see a short evidence review, but essentially this is just my recommendations. So creating a new code grouping called benign neoplasm and conditions of the external female genital organs. There are really long tables at the end of each of these documents that go through in excruciating detail which codes and which procedures. And those of you who work for CCOs or you might be really interested in this type of thing are probably going to get really interested in looking at those. Others may just kind of look at them in your eyes when you have insomnia some night. But there's a group of codes that mostly are from like Bartholin gland cysts and then vulvar lesions. And then there'll be adding one code, which is destruction of vulvar lesions. So that would be a new code grouping. There'd be a little bit of expanded treatment for a few of these conditions. There would be another group that would be created for pelvic pain and dysmenorrhea. It would contain most of the codes that are currently in our line 525, which is our chronic pelvic pain, although some will be distributed among other groups as well as dysmenorrhea. And then we're keeping guidelines. A lot of the guideline changes are just technical. You heard that we're not using lines, we're using code groupings. We're not using on this line, we're using medically necessary. So just those things. So you'll see. So for pelvic congestion syndrome, for example, vein embolization will continue to not be medically necessary. For pelvic pain and dysmenorrhea, we're going to have essentially the same guideline, except they thought that non-malignant cervical cytology should just be up-to-date cancer screening because we are now so far, we've advanced so that, you may have had your PAP 4 years ago, and that is actually up to date. And then we are putting in here something called date of last review. This one actually should say February since this is actually February, but we're doing this because the CCOs have been asking us for a while, and we have to look in minutes. So we're going to try to keep this up so that it's really easy for folks to know how old this is and whether, if it was reviewed 3 months ago, it doesn't need probably to be looked at again. If it was reviewed 9 years ago, it probably should. Some guidelines can be deleted, like our chronic pelvic inflammatory conditions are not we're not doing some of this stuff that was kind of done to kind of jerry rig and like not have certain codes pair. That's not going to be a problem anymore. Opportunistic. Oh, I forgot to mention the hysterectomy guideline that was there. That is pelvic pain and dysmenorrhea. They actually were two separate guidelines, but they were exactly the same. They were almost like word for word, almost exactly the same. So we just combined them because it just felt a little bit overkill. And then opportunistic self-injectomy will remain the same. Again, just medically necessary will be replaced. And then you can start to see there are all of these things. So many, many things are in this evaluation of medical management. Like I said, office visits, specialty consult, education, etc. Things like chronic self-meningitis and oophoreitis, our experts said that you can't make this diagnosis until surgery, so it should just probably be in a surgery group. And then you can kind of, if you just keep paging down, you'll see a lot of these things will will kind of fall into some of these groups. You'll see a couple of things. I think if you go down, even at the bottom of this page, you can see a few things. So line 433 is precancerous vulvar conditions. That will become code group 43. I'm just moving this diagnosis over there. So you'll see a few things that are already existing lines, which will now be code groups. And then the procedures will kind of follow them. So it's a very different way of looking at things, but again, not a lot changing. There will be more coverage for certain benign external genital conditions, and we will be covering hysterectomies for dysmenorrhea and pelvic pain. Whether or not that's a huge change is up for debate. What kind of questions do folks have? Larry, did you have a new question? Is your hand still up?
Sorry, now I do. So if I understand correctly, that all the listings of these codes and descriptions, that they are all now being covered. Is that correct?
So when you see something where it says evaluation and medical management,
Uh-huh.
that's already being covered. That
Okay.
is the status quo.
Okay.
So you have vaginismus, which is a painful vaginal spasm.
Yeah. Yeah.
You can see your gynecologist or your PCP. You can have pelvic exam, education. That we will not be pairing it with physical therapy. We had this quite long, detailed discussion in the last year about this with our gynecology colleagues, and decided not to. But again, in the future, maybe that would be a question that would come to us and say, should we have a different group for things that need physical therapy? So maybe we would move that code over to that group rather than just being kind of in the basic evaluation of medical management. So yes, all of these things are now covered, but most of them are covered in exactly the same way they have actually been covered for years. There will be some new things. Those are the ones where you see, like right on here, you see female pelvic peritoneal adhesions that would be in pelvic pain and dysmenorrhea. Bartholin gland cysts would now be treatable. So some of these things would have more than just an office visit and whatever diagnostic tests and treatments. They might have a surgical treatment that would be available to the gynecologist.
Okay, great. Thank you. That makes a lot of sense.
Ariel, is all of this effective 1/1/27?
Yes. Yeah, nothing in here is proposed for change until before 1/1/27.
Oh.
Another way to put it is if you see a diagnosis listed here and it says evaluation and management only, and you're aware of an important service that would help that, we want you to call that out for us and we'll
Or alternatively, if you see that I've suggested that we allow a procedure and you feel that you want an evidence review, you don't know if that's appropriate, you would like me to talk to the experts more, all of those are so what we've been doing, we've had our trial run at VBS and HERC in January. And what we have done is we've kind of approved, if that's where you kind of get to today, you approve this, but you may pull out like these 3 diagnoses I want staff to look at more. And then you approve it minus those three. Staff looks at those, we consult with our experts, we do research, we do whatever is needed, and then those come back later. If you don't like the proposal at all, if you think, no, this is completely the wrong direction, I don't like half of this, then that happened with one thing at VBS. There was enough of a problem with some of the things that they wanted me to just rework the whole thing. So those were kind of the options moving forward.
Great.
Deb, I
Thank
see
you.
your hand up, and then I see Mark's hand up.
Thank you. So from the perspective of acupuncture, for example, there is quite a bit of conversation and practices in treating vulvodynia with acupuncture and PT. So as this stands, the evaluation and medical management, I think, is what I think was there. Even middle schmerz, I've seen folks where that's, it really knocks them out, that mid-cycle ovulation pain. And we work with that with acupuncture and can get people to a place where moving them past it. And I know too, there's a big movement in Portland, kind of epicenter of PT for vulvodynia. So it sounds like that would be
So
covered out of pocket.
So vulvodynia, vaginismus, those types of things we've talked about in the last year in a lot of detail. So I think that's kind of a decided. And then I just wanted to let you know
thank you.
that we have been working with the Oregon Acupuncture Association. They've had a huge list of things, and there were some gynecologic things on there. So there's already been a question raised, and what I think I'm going to do with that is it's going to be separate from this. So if because they wanted so many things looked at, maybe next November, next August, we'll decide, yes, there's good evidence for dysmenorrhea, that acupuncture can help. And then we would probably add acupuncture for dysmenorrhea starting in 2026 on the current line on the prioritized list. And then dysmenorrhea would be in the code grouping for acupuncture.
Okay, thank you. That's
this.
also.
Yeah.
So their bench. So medical management would not include PT, would not include
It does not include
acupuncture or
PT. There is
chiropractic.
the medical management is just office visits, diagnostic tests, education, medications. There is a group for PT that is going to have a lot of things. We've
Yes,
had a lot with like our sports and ortho folks that we've talked to. Yeah.
I'm glad to hear you've been in conversation with them. And I've made sure that the Oregon Acupuncture Association knew and
Yeah, and I'm pretty
naturopathic,
sure
so I don't know if they've been talking with you.
Yeah, I've just done a very early look, but it looks like dysmenorrhea is probably going to be one that might move forward out of that acupuncture review. But
It would make sense from how I see it affect people sometimes.
yeah,
Thank
but
you.
I think I'd rather do acupuncture kind of since they had so many asks, I'd like to kind of rather than just review one piece of this for acupuncture, I think I'd like to kind of maintain the acupuncture review.
Yeah, I hear you. That makes sense. Thank you.
Okay. Mark?
Ariel, I really appreciate all the work. And I guess my question would be, this seems very much a local coverage determination. And I know when we are looking at other processes, we look at national coverage. Do we look at other Medicaid coverage for other states, how they do some of these more elective type procedures? I know we have the mandatory and we have the not medically necessary, but in this gray area, is there a list of other states, and what's our policy or thoughts on looking at that?
As a general statement, yes, I look at Medicaid states all the time. Washington Medicaid and Oregon Medicaid we're like buds.
Okay.
Christian is on my speed dial. Also, we're part of the Medicaid Medical Directors Network, which is a national network of all the Medicaid programs, and frequently we'll post a question, hey, does anyone cover acupuncture for dysmenorrhea? Or something like that. So every state can determine their own Medicaid program according to their own rules. Some states have very explicit, nicely written out, easily sent over and looked at. Other states, it's just kind of this like, yeah, I don't know, it's somewhere. But yes, we do.
Okay, so looking at this list, this has already been vetted. This is standard among other states. This is.
I have not asked other states to look at these lists.
Okay.
I have talked in general, like at med meetings and the National Medicaid Medical MMD. I can't talk today. In general, just kind of about our process, we are by far the most detailed of all the Medicaid states. There's a lot of Medicaid states that say a cardiothoracic surgeon submits a bill, we pay it. We didn't even look at it. And actually, that was my one thing that was like the thing that made me the happiest that is going to be next month is all of the congenital heart disease things are getting condensed down to one line. We have 19 lines for different congenital heart diseases. Why? Just fix them. So,
But it's
and
clear
some
though.
states also do like quantity limits. You can have acupuncture, but only 20. We don't care for what. Some states, anyway, having this condition treatment pairing for every single thing is highly unusual.
And I'd say the states have the authority to do whatever they want. And for today, if you're seeing some stuff on here and you think, oh, I'm not sure that might need a guideline note, that I'd like to know what other states think.
Yep.
Flag the diagnosis or the procedure, and Ariel will bring it back.
I have a question. I'm looking on page 125 at the bottom. It says R37, sexual dysfunction, unspecified, and there is evaluation and medical management. That's for women. But I understand that so I have a question. Is that covered for men?
So sexual dysfunction unspecified is an unspecified code, meaning a dump code. There are many more very specific diagnoses for both men and women, and they're covered.
And they are.
Yeah,
Right.
and we did urology in January, so some of these very similar diagnoses were reviewed at that point.
There are some specific treatments that aren't covered for both men and women.
Correct.
Okay, so this gets back
So I
to
want to be really
medically necessary versus medically versus whether they are covered. Okay.
So
I want to be mindful of our time, and like I'm seeing that we're creeping up on 28 minutes till 5, and I want to be able to either complete what we need to complete today and or re-guide people. If you're looking through this and you see things, do you want us to go through this verbally right now and then pick things out? Do you want us to go back and look at them and email back? Is there, do we need to go through each of the last 4 topics? I just want to be mindful of, because most of us could go through this and we'll be doing what you've been doing, Ariel. We'll be here for months. So I just want to think about what do we need to accomplish?
So what I
next...
need this group to accomplish
yes.
is just if you could just look through, if anything strikes you, wait a minute, I see this doesn't make any sense to me, flag it for me. You can do it now. If you want to wait and do it this weekend and email me, we will pull individual things out. If in general you agree with everything, except for perhaps you want me to look at this diagnosis or that diagnosis, then you would approve this and it would still needs to go to HERC for their decision. We're using you instead of VBBS, basically. So just to have more brains and more eyes.
Do we need to have an action today so that it can move forward, or do we have some time? I'm just looking at the level of detail and the level of, and we're on the first topic. So I'm just
Right.
being
So
mindful of
I,
what's a best process for right
right.
now.
Ideally, we would move this to say we'll move it to the HERC for a decision. I'm um I do realize this is far more detail than you're used to. Um yeah, so
I mean, I'm used to it because I sit on HERC, but I do know that this is not the way
th
EVGS
this
is
group is used to.
typically
Yeah.
used
Well,
to going through this. So just, I just want to be mindful of this is a change process for us. What's the best way to accommodate that and make sure that we're meeting um, what the intention was to accomplish today, and what the timeliness of these decisions are
yeah.
that we need to make.
So I think we would like you to vote and move as many of these as you feel comfortable to HERC for review. If you are not feeling comfortable doing that, we can bring them back. If you only get to one, that is okay. We will need to catch up later. But again, the goal today was to scan through these, and if anybody had questions or concerns, flag the ones that need further review and send the rest on if they're not controversial. So I don't want to get into, for example, a in-depth discussion of procedures for sexual function today, but we could flag that for review and bring it back to a future meeting. Same thing with hysterectomies or whatever else. So that's the kind of level of review we want to flag anything that you want to look at in more depth. And then, if there's not anything, approve it. If someone notices something later, as is always the case, anyone can suggest we take another look at something. But our goal is to rough this in today, knowing that it will be imperfect.
So, hearing that, all of us, what is your sense of, can we move anything forward today? Do you need more time? Can we move the gynecological items ahead? How are you feeling? Because this is again, a change of process for us as a subcommittee. And again, we advise the HERC what we think will happen. HERC will be the place where decisions are made. So it isn't that things won't be reviewed again, there won't be more eyes on. You can make comment later if we do decide to move a piece of this forward.
Yeah, I see your hand up.
I'm what people are thinking.
Yeah, so I guess so I see that there's a code group that's not medically necessary, and then I guess in a future in dermatology, I see that there's an excluded one, and none of these in gynecology are necessarily recommended for excluded. So I'm still trying to figure out, where the options are. But that, for example, that question of sexual dysfunction. So if that's not excluded and it is evaluation medical management, then does that mean Viagra is now covered for women?
No. So all diagnoses a diagnosis cannot be excluded. It has to be available for a medical visit. So even infertility, if a woman comes to their PCP and says, I haven't been able to get pregnant in 5 years, you can still counsel them and say, I can refer you to a reproductive endocrinologist, but it probably won't get paid for, but your office visit would get paid for. So there's no excluded diagnosis. Some procedures will be. And we are still internally really working on, there will be two and possibly three groups. So a procedure might be in a procedure group. So hysterectomy, all these conditions need hysterectomy, they're in this code group. There might be a not medically necessary, like a treatment that is either not done anymore. We have a lot better treatments for it. There's just, it's just really not medically, so it's not medically done, but maybe there's 1 in 1,000 patients with some strain, with a really complicated medical history where that's actually the procedure they need. If it's not medically necessary in that category, you can still do an exception. If we say it's excluded, it will be outside of the benefit package. It will not be funded. It will not be available for exceptions. I guess it might be. I mean, I guess the CCO could just figure out another way to pay for it, but it would always be outside of the benefit package and the typical funding stream.
So the most base for every single ICD-10 code at a minimum then will have evaluation of medical management.
Correct.
Got it.
And procedures might be on multiple lines, multiple code groups. I'm trying to kind of condense things down to kind of code so they're more like lumped in code groups that make sense. They might not be medically necessary. They might be excluded.
I think there's a lot of complexity here that I think even for us that as we move through this process, I really appreciate getting to that level of articulation. And I think the important piece also is you've vetted almost all of this with subject matter experts who are practicing in those fields. And that's where a part of the review has come from as well. So we could potentially say yes or no, but I'm not sure. Do folks feel like they have clarity about what they're saying yes or no to? If we were to move this to go ahead, like the gynecological review work to go on to HERC, are you clear what that would be doing?
So yeah, that's a great point, Linnea. So if you decide you approve gynecology, what you would do is you would be approving the creation of a couple new code groups that have procedures that previously were below the line that will now be covered. There will be a couple of those. I may in the future condense things down further. Like there may just be one code group for hysterectomy, and it might include all kinds of things. But right now we're continuing to have hysterectomy for dysfunctional uterine bleeding, hysterectomy for uterine cancer. We're still going to keep some of these groups just because I can't, and I just do not have the time or the bandwidth to do all of the covered. So we're looking at the uncovered. So you are creating a couple new code groups. You are adding some coverage. There will be some additional coverage for some treatments of cysts, Bartholin gland cysts, etc. That if you feel that that is appropriate, that would eventually go to the actuaries. They would price that. There's be added coverage for hysterectomy for pelvic pain and dysmenorrhea. Again, my gynecology experts are saying that they don't think that that's actually going to change things. They just think people have coded things differently. I'm not sure if that's reality or not. Again, that would go to the actuaries and they would look, and what they are doing is they're looking at commercial payers because a lot of this stuff is never billed because we've never covered it. So dysmenorrhea and hysterectomy would, if we looked at Medicaid data, we would find none. But if we look at private pay, Blue Cross, MODA, all those, we should find some percent, and that will give them a sense.
Mimi has her hand up.
Oh, thank you. That was just my question. I think you answered it, Ariel, is in terms of when it does appear that there is going to be an additional coverage of a service, certainly for a condition, and I think dysmenorrhea and chronic pelvic pain. I actually might disagree with those colleagues since that it actually will increase coverage, which is, well, I won't get into my opinion, but anyway. However, it is good to know that the actuaries are going to do an evaluation and that information will be shared, I think, with the CCOs and other things, because it certainly, I mean, that could have a significant impact.
I guess I would caution, I don't know if it'll be shared or not. They will factor it into their rate making.
Yeah, it'll
That's a
be
separate
separate.
discussion.
Yeah.
Okay.
But again, your decision is not about the money.
I understand.
If
I
you
understand.
think we're going too far with this, say,
Yeah, Mimi, if you think that dysmenorrhea really is not an indication for hysterectomy and you want me to do a deeper dive, I'm That is something you can call
Thank you.
out, and I will do.
No,
Good
I'm delighted,
question.
actually.
I'm sorry.
I said
do?
I'm delighted, actually.
Okay. Okay.
Yeah. Quick question. So I've looked through the 5 sections, and it looks like overall that coverage has been consolidated and overall increased. Is that
That
correct?
is the general sense, yes.
Yeah,
Great.
one of the basic things that I didn't say in my presentation, I wish I had, no coverage will be decreased as a result of this project. We're looking at the unfunded region, so either it'll stay the same, like evaluation and management only, or it'll be increased. Or
I
it'll be recoded and restructured to net to either equal to or greater than current
okay. So to answer Linnea's question, I'm comfortable with sending this on to the HERC.
Are you
Kat,
making a motion?
Oh, I see Kat's hand up
I
first.
I don't want to do that yet. I want to see what other people have to say.
Okay, Kat?
Yeah, well, I guess my interpretation of the Mimi Ariel conversation that just happened is that Mimi wanted to do some thinking about the dysmenorrhea guideline. So that seems like one. And then the other one is that if there are totally new things that are potentially covered, for example, sexual dysfunction, there's never been a guideline note on it since it's been below the line. So it seems like there would need to be a new coverage guideline about sexual dysfunction added, right?
So sexual dysfunction will only have medical visits. We already have federal rules about medications. It will not be paired with physical therapy. What other pieces would you need a guideline for? What other?
Medication I'm thinking of.
We cannot pay for erectile dysfunction meds. That's a federal rule. Something like topical estrogen, for dysmenorrhea. I don't know if we're PAing that. That's probably already getting paid.
That's for PNT.
Yeah. And then I heard Kat you saying something about the dysmenorrhea pelvic pain hysterectomy guideline. Are you concerned about that?
I guess I heard that Mimi was concerned about it, so I wanted to.
So maybe it's good to take a little temperature right now because we keep looping back like we have specific lines or specific questions. And I'm going to do this just with like, because most of us are on camera. Are people wanting to move anything forward today? Or are you feeling like there's so much information or you're not clear about what's going on that you want to get together again, go through each of the, like think about them and go through them? So that's one option. Uh, One is to move them today. A second is to convene another time to talk about them. And the third is to just set a timeline for some email or those kinds of responses directly to Ariel, move them forward, but then have a time in which you could correspond with her. Do any of those resonate with people?
Yeah, yes, I'm comfortable with the moving forward. However, if anyone else wants to go back and relook at things and after some period of time, I'm okay with that too. I'm okay either way.
Abby, I see your hand up.
Yeah, I was gonna say I feel like personally it would be nice to have a little more time now understanding what I'm looking at to go over these. That said, it does really sound like these are going to be well thought about at the next level. So I have to say that I'm also okay in trusting these are good enough and moving them forward. But if you ask me personally, I would probably want to read a little bit more.
My kind of reading of the room then, we're not going to get to derm at all today. That's okay. One of the things is we're publishing a lot more than we think any meeting can actually get done, just so that they're out in the world and people can look at them and specialists can look at them and CCOs can look at them. So every time we publish a packet, it's more stuff's in the world. So I think dermatology has been tabled till our next meeting. So we're really talking about gynecology today. And I think I'm not hearing any specific pullouts from anyone. So you have a couple options. We could either approve it to go forward to the HERC kind of as is. We could approve it to move forward to the HERC as is. And then people can individually get in touch with myself, Jason, any other HERC staff with, if when you feel like you've have a little more time and want to go with more detail and you're like, hey, wait a minute, I actually didn't notice this and I want this looked at. And then at which time the next HERC meeting is not until March, so that gives us time, we would pull it back and say, EBGS wants you to approve this minus this one piece or minus this one piece, but here's what staff has done further, and this is what staff's recommending. Or we could just say we're really uncomfortable with this whole process and we want to go through it again in April.
I'll make a motion that we forward the gynecology section on.
To approve the gynecology recommendations as presented to go to the HERC.
Yes.
I would second that.
So do we need to restate the motion? Everybody clear on that? We take a vote to move the gynecological section on to HERC. We would take a verbal roll call. Jessica?
All right. Linnea Lindsay.
Yes.
Mimi McDonald.
Approve.
Mark Buckles.
Approve.
Deb Espicente.
Yes, approve.
Abigail Khan.
Approve.
Larry Lyon.
Approve.
Kat Livingston.
Approve.
Judy Richardson.
Yes.
Sounds unanimous. Motion passes.
And then Mimi, I see you have a question.
Oops. Yeah, thanks. So what would be the best way? I don't know if it's emailing you, Ariel, or something like that, when we do want to look at, like, for example, I do want to look at the guideline notes around coverage for hysterectomy for pelvic pain or dysmenorrhea. Just email you or
email me directly or the HERC.info. Well,
Okay.
either of those would be perfect.
Okay.
And even though this group has voted this forward, if you or any other member of this group has a question that, you're like walking your dog tomorrow and you're like, wait, send it to us. We will flag that for HERC and say EBGS approved it. However, we've been asked to look at this. And if it's significant enough that we feel it changes a lot of this, then we may just bring this back to you altogether. I suspect it'll just be, I will work on whatever question you have, and it will come to HERC with an addendum. Cat, all my best thoughts are on rocking my dog. Mine are in the shower for some reason.
We have 8 minutes left.
Yeah, and I want to thank you all. I know this is very outside of your comfort zone and what you're doing. I really want to thank you all for being willing to be an extra source of help. This is a very large project. As you can tell, there's lots and lots of detail. As I mentioned before, everything will be published for all the below the line 6 weeks prior to our May meeting. And then we're planning on everything being decided by December. So for example, if HERC does not like some of this gynecology stuff and they make us work on it, it might take a couple meetings before it's done, but eventually we'll have this whole product done. And before our April meeting, all of the dermatology things will be on this list. I don't believe we have any coverage guidance at this point. So you're going to be doing all of the dermatology, and you may end up getting something like very meaty like ENT. ENT is very, very meaty. So yeah. And then you're also welcome again to get in touch with me, get in touch with Jason, HERC.info, and you're welcome to come to the next HERC meeting and just kind of listen in or be part of that conversation as well.
Yeah, and we're sending these out 6 weeks in advance of the meeting. In this case, we actually sent it 7 weeks because 6 weeks would have been Christmas Eve, I think, or Maybe it was just because it was ready earlier. But we didn't get any public comments, and we'll include you all in that distribution. We take public comments from members too.
And other topics have gotten public comments. This particular one didn't, but others have.
Yeah. And so we just want to, like, if you're able to read these materials before, it's probably easier to see what to zero in on than in the heat of a meeting or watching it fly by on the screen. Just really encourage that. This is really one of the broadest scope impacts you all will have as a part of your service. And so I'd really encourage you, if you're able to make time for that, we would really appreciate it. And I'm sure the OHP members would appreciate having this policy closer to perfect, more perfect, as they say,
More better.
as it goes out January 1st.
Yeah, and as you'll see when the packets come out 6 weeks ahead, if you're in our Gov notice, if you happen to be someone who works in an area or you have colleagues that you know are very interested in an area, please flag it for them. There's a 2-week open public comment period. We welcome public comments from anyone. And the public comments have changed the staff recommendations that have come. So they're very important. Kat?
I want to correct one thing Ariel said. Liz just alerted me to this. So I think Ariel said, if I heard right, this would be posted 6 weeks ahead of the HERC meeting. That's actually today. It's already been posted. And it doesn't have to be posted separately. We will include it as a handout as soon as we can, since you all approved it without any modifications. But as a matter of course, the 6 weeks goes before the committee hearing, and we won't be able to do a full 6 weeks prior to that.
I didn't actually mean 6 weeks before HERC. I meant 6 weeks before the subcommittee or HERC meeting. Okay. So I apologize if I confused anyone. Kat?
Is there a master list of the new and evolving code groups?
Jason.
So we are just trying to keep our heads above waters with decisions, but we're hoping to get to that soon. And what I will say, since we just have a couple minutes, Liz, if you could go to that.
Kat, if you look at the January VBBS minutes, I believe they've just been published. They have appendices at the end that are all of these code tables and guidelines. So that anything that's been approved, you'll see in the minutes. And we are going to make something public. We just don't know what yet.
So it'd be like a searchable code group function would be really awesome.
Yeah. That is a goal.
We'll hope to get there. Yeah. So Liz is pulling up this benefit update project work plan. And if you scroll down there, you'll see already notes about the decisions that were made at January VBBS and HERC. You'll see the items on the agenda today, and we'll go through and update this next week, so it'll be fairly up to date, and then you can refer to the meeting materials and minutes to determine what happened. But the update,
and even if you
probably a couple months away.
If you look at the January minutes and you are concerned about something that was even HERC approved, please feel free to send it to us. We're trying to be as good as we can, and then we figure that the more eyes and the more brains that look at this, over the course of the year, we'll get closer to perfect.
You all are amazing.
And I do want to thank all of the specialists who have taken so many hours to meet with me.
Yeah, we've had some great volunteer specialists. Okay, and then the next meeting is April 10th. Same place, same time, although we will have an in-person option. If any of you want to come in person, we can do it in person, although this group seems to prefer online. Jessica will be polling you about that in the coming days.
And again, thank you. And thank you for your flexibility. Our CEBT team is amazing with their coverage guidances, and I'm so happy to work with them. but thank you for completely pivoting like 180 degrees to do a much more practical, not evidence thing.
And I appreciate everybody's flexibility to pivot, but I think it's a good dry run for us, and I appreciate letting us wander through so we can get further clarity, because I think if we don't do it, we're not going to understand what the work or the role is, which is why I was trying to push some process conversation into the
Yes, thank
to
you.
what we were doing. So I think we just have some great opportunities. And the other thing I was going to say is we've had such a high level of detail in our work compared to what other states have done, that it's almost like we have to kind of move upwards from having such detail to more generalization, more flexibility, more openness, to not having every little thing locked down. And that's going to be an uncomfortable transition for a lot of us who are used to, this is what the evidence says, this is what we're going to do, this is where we've gone, because we've done that for a couple of decades. And this is a pivot in a different direction. Um, but the sadness or the grief for a lot of us is people have looked to the work we've done across the nation and seen it as very valuable. So it'll be interesting as we kind of move back into a more normed kind of way of
But
processing this. We won't
and your
lose what
work
we've
is
done.
not gone. Your work
No, it's
continues. We're just
that's
it's
what I'm thinking.
just
It's not gone. It's just different. Yeah.
yeah, we're just dressing it a little differently and having a slightly, think of it as it got married and, it now is like grown up in a different house with a different last name maybe or something, but it's the same.
Okay, Ariel, we'll go
Okay,
there with
sorry. That
you.
was
Bye.
probably like wrong in
No,
so many different. Anyway.
no. Yeah, lots of good work ahead, folks, and we need all the subject matter expertise and detail that we can continue to bring to this work. So I appreciate. Thanks.
We appreciate all of you. Thanks.
Bye, everyone.
Oh.
Have a good evening. Thanks. Bye.